A very good evening to all of you. I guess I'm live. Am I visible? Am I audible? Everything is good to go? Can you write down something in the chat box so we can start the session ahead? Hello, people. Is everything is good? Yes, thank you. Thank you so much. So, a very good evening to all of you. And on this evening, I would like to tell you that today I am going to cover, just a second, a rapid revision of pharmacology. Okay, so pharmacology is considered to be a difficult subject, but believe me, I will make pharmacology super easy for you. So at the end of the session, you will feel confident in the pharmacology. Just a second. Okay, so today we are going to take the remarkable rapid revision of pharmacology. Now in the pharmacology, how many units we are having? We are having all these units in the pharmacology. You can see all these units. Now covering all these units in one day, in 3-4 hours, it's difficult. That's why we have divided the session in 2 parts. So today is part 1 and after that we have a part 2 also. So all these topics you can see I'm going to cover today in part 1. So today I will start from the general pharmacology. I will start with pharmacokinetics, then pharmacodynamics, then antimicrobial drugs, all the antimicrobial drugs, the biggest chunk, and definitely you are going to get many questions from that. Okay, and then renal system, respiratory system, cardiovascular system. These systems we are going to cover today. And in the next session, that is part 2, which is launched on the same YouTube channel where you are watching it right now on the 13th of Jan. Okay, so today is the 4th of Jan, and after, I guess, few days on 13th, we are having the part 2. So in the part 2, we are going to take the remaining pharmacology, that is ANS, CNS, GIT, endocrine, autocoids, blood, and anti-cancer. So these topics we are going to take in the next part, because I want to tell you everything, each and every topic in the pharmacology, which is going to be asked in your exam. Okay, so this session is going to be super useful for your exams, believe me. So without wasting any further time, let me start. The session will be for the next 4 to 5 hours. Okay, in next 4 to 5 hours, we are going to cover this complete chunk. So starting from pharmacokinetics till CVS, we are going to cover today. So maybe 4 hours, 5 hours, it will be taking approx. So let's start it. Can I start? So let's start with the first part, general pharmacology. So from this topic, one by one, I will take and cover all the relevant stuff from that topic in the simplified manner, super simplified manner, I must say. So let's start it. Can I start? Thank you so much for your compliments. Let's start with the first topic, pharmacokinetics. Okay, now in pharmacology, what is pharmacology, by the way? Pharmacology is the study of drugs. Okay, now in pharmacology, we are having 2 branches. What are the 2 branches of pharmacology? Pharmacodynamics, okay, and pharmacokinetics. Okay, now we have to understand what is pharmacokinetics and what is pharmacodynamics. Then we will see the details of that. So what is pharmacodynamics? What the drug is doing on the body, what the drug does to human body. And what is pharmacokinetics? What the body does to the drug. What do you mean by that? What do you actually mean by that? Let's take example. Now this is the master diagram in which I am going to teach you entire pharmacokinetics as well as pharmacodynamics. These 2 topics I will teach you in this diagram. So please understand this diagram well. It's a master diagram, key diagram, super diagram. Now in this diagram, I have shown you there is a drug. This is a drug which is taken by oral route. The most common convenient route is the oral route. So drug is taken by the oral route. Just suppose I am the patient and I am having some disease. For example, I am having headache of migraine headache. I am having some heart failure, or I am having diarrhea, constipation, or any of the disease. So I am taking a drug for that. To treat that disease, you are a doctor and you have prescribed a drug. I am taking it by mouth. That is oral route. So what will happen? The drug will go inside. Now there is a rule. The drug will get absorbed. So acidic drugs are absorbed from acidic medium, that is stomach, and basic drugs are absorbed from basic medium, that is intestine. So the organ of absorption of different drugs is different. Acidic drugs are absorbed from stomach, you know the reason, and basic drugs are absorbed from intestine. After absorption, the drug reach in the blood. So this step is known as absorption. What is the definition of absorption? Can you tell me the definition of absorption? It is the movement of the drug from where to where? From site of administration till circulation. It is not necessary that drug is always given by oral route. If the drug is given by intramuscular route, or it is given by any other route, it is inhalational route, it can be any route, rectal route. So from that site of administration, it is ultimately reaching in the circulation. So it is the movement of the drug from where to where? from the site of administration till circulation, this portion is known as absorption. The drug is absorbed. Now the drug is in the circulation. The drug is in the circulation. Now from the circulation, drug will move to its site of action. If I'm taking it for migraine, the receptor of that drug is supposed to be on the cranial blood vessels. And if I'm taking it for some intestinal disease like diarrhea or constipation, the receptor is supposed to be on the intestine. If I'm taking for heart failure, the receptor is supposed to be on heart. So whatever is the organ of function, the drug will move to that organ and show its mechanism of action. For example, I'm taking for migraine, my migraine is treated, the drug worked on my that disease. Now the function of the drug in the body is over. Now, my body want to excrete the drug. Now, it is not there the drug will remain there forever. No. Drug will not remain there forever. So, drug will come in the blood again. And after coming in the blood, most of the time, drug excreted in urine. 99% time. Very rarely it is excreted in other forms like feces, like saliva, like breast milk. But most commonly, it is excreted in the urine. So, drug is going to the kidney and asking the kidney to excrete it. But kidney is saying, no, I cannot excrete you. Why? Why kidney is not excreting the drug? Because most of the drugs are non-polar. What is urine? Urine is water. So only water-soluble drugs will be excreted in urine. What is a water-soluble drug? Water-soluble drug is polar. So first we have to convert non-polar drug to polar drug. So kidney is asking the drug, first you get convert from non-polar to polar, then come back to me. Then I will excrete you. So what the drug is doing? The drug is going to the liver and asking the liver, can you please convert me from non-polar to polar? My job is over. Now I want to get excreted. So liver is saying, yes, come inside my hepatocyte, and inside my hepatocyte there are enzymes that will convert you from non-polar to polar. So converting the drug from non-polar to polar, or else say hydrophobic to hydrophilic, or else say lipophilic to lipophobic, one and the same thing. You know, water and fat are inversely proportional. So hydrophobic to hydrophilic or lipophilic to lipophobic. You got my point? Or else, non-polar to polar, one and the same thing. So this step is known as biotransformation or metabolism. So first step is absorption. The drug get absorbed, reach in the blood. From the blood, it is distributed in various organs. This step is known as distribution, in which it is going to various organs and show its mechanism of action. Then it is going to the liver and showing biotransformation or metabolism, the meaning of which it is converting from non-polar to polar. And finally, it is excreted out of the kidney. So 4 things are happening, people. 4 things are happening. Can you tell me what are the 4 things? Can you please summarize? So what the body is doing on the drug? Say, ma'am, body is first absorbing the drug, taking the drug from the site of administration to the circulation. Then body is distributing the drug. That is taking the drug from the circulation to various organs. Then body is metabolizing or biotransforming the drug. That is converting the non-polar drug to polar drug. And then body is excreting the drug out of the body. So 4 things the body is doing on the drug. Say yes, people. So this is known as pharmacokinetics. What the body is doing the drug. Say, ma'am, body first absorb the drug, then distribute the drug, then metabolize the drug, then excrete the drug. These 4 things are known as pharmacokinetics, PK. Pharmacokinetics have 4 branches. And what the drug is doing on the body? Drug is doing only one thing on the body. Can you see? Drug is showing its mechanism of action on the site of action. That's it. So this portion is known as pharmacodynamic. So see, I'm writing PD here. Pharmacodynamics have only one part, that is mechanism of action. But pharmacokinetics have 4 things, that is absorption, distribution, metabolism or biotransformation, and excretion. How many of you got it, people? How many of you got it? Give me a thumbs up. Everyone. Jitno ko samajh mein aaya, give me a thumbs up. Huh? Say yes. Got it? Kindly respond, everyone. So what is pharmacodynamics? What the drug does to the body? Only one thing, mechanism of action. That's it. And what is pharmacokinetics? What the body does to the drug? 4 things. Absorption, distribution, metabolism, excretion. Yes, you can of course learn a mnemonic ADME if you want. If you want to learn a mnemonic, it's absorption, distribution, metabolism or excretion. Or you can learn with the help of the diagram. Okay, how to learn? You can get confused in the exam now. Learn D for D. So pharmacodynamics is PD and what the drug is doing on the body. Drug. So PD is what the drug is doing on the body. D for D. You can learn. So you will not forget. So read the question. Tell me the answer. Simultaneously we will solve all the PYQs. Okay. Specifically for the FMG aspirants. Okay. Read the question and tell me the answer. Quick, fast. What pharmacodynamics deal with? I'm asking for PD. PD. I told you the mnemonic D for D. I told you the mnemonic. What the drug does on the body. है ना? So correct answer is A, and you all are absolutely right and fantastic. So correct answer is effect of drug on the body. If I change the question to pharmacokinetics, answer will become B. Effect of body on the drug or absorption or metabolism. All the three options will come here because they are the parts of pharmacokinetics. Okay, now coming on the next question. One more question for you. Pharmacokinetics include all except what is not included in pharmacokinetics? Absorption is there or not there? Distribution is there or not there? Adverse effect, excretion, what is not there? So of course, absorption is there, distribution is there. The third step is metabolism, not adverse effect. And finally, excretion. So adverse effect is not a part of pharmacokinetics, so excluded. So correct answer here is C, and you all are absolutely right. Coming on the next question in front of you, read it and tell me. Pharmacodynamics include what? PD. What is PD? PD have only one thing. Is it elimination of the drug, excretion of the drug, absorption of the drug, or mechanism of action? PD is what the drug is doing on the body. So it is only one thing, the mechanism of action. So if you learn the master diagram now, in this master diagram, it should fit in your mind and things will become super duper simple. Okay. So this is the first portion we have completed. Now let me tell you the factors which affect the absorption of the drug. The first portion is absorption now. So I told you the first part is absorption. What is absorption? Movement of the drug from the site of administration till circulation. So there are many factors on which it depends. The ultra important factor which I want to discuss here is the effect of pH. So does the pH is affecting the absorption and excretion? Of course it is. Listen, let me ask you something. You want the drug, let me ask you, all are doctors now. You want the drug to be absorbed more in your patient body or excreted more in your patient body? I'm asking you, can you give me the answer? Then I will explain you the effect of pH on the absorption of the drug as well as excretion of the drug. I'm asking you a question. You understood my question? Being a doctor, what do you want? Your drug, whatever you are prescribing to your patient, it should be absorbed more in the body or it should be excreted out of the body. What do you want? What do you want? Being a doctor, what do you want? So yes, most of the students are saying absorption as expected. So Govinda is saying both. Why both, Govinda? In what case you want excretion, Govinda? So let me tell you. Imagine there is a patient in front of you having some disease. So of course you want to treat the disease, so you want absorption more. So you all are right. But imagine a patient is in poisoning. Patient have taken overdose of the drug because of suicidal attempt, homicidal, or any by accidental, anything. Patient have taken 100 tablets together. In that case also you want absorption? No. I want excretion. I want to save my patient, the poisoning. In that case I want excretion. So it is not necessarily we always want absorption. We want absorption if we want to treat the patient, a disease in the patient. We want excretion in case of poisoning. So depending what we want. Say yes, so we can want more depending on the situation, depending on the condition. Got my point? Now let's say there are two type of drugs. If the drugs are electrolyte, there are two type of electrolytes. Strong electrolyte, in the chemistry you have read it, and weak electrolyte. Strong electrolyte do not ionize. We know the rule in chemistry in 7th, 8th standard we have read that. But weak electrolyte do ionization. They ionize. So pH affect the weak drugs, weak electrolyte drugs. There is no effect of pH on strong electrolytes. The strong electrolytes are equally absorbed from acidic and basic medium. Acidic and basic medium do not affect them, the strong electrolytes. But weak electrolytes, the pH matters. So how does the pH matters? So now please remember, we are talking about weak electrolytes. We are not talking about strong electrolytes. Because strong electrolytes पे effect ही नहीं होता pH का. Whether it is acidic pH or basic pH, strong electrolytes are absorbed from both of them. But unfortunately, most of the drugs are weak electrolytes. They are weak electrolytes. So let me tell you the effect of pH on absorption first, then excretion first. Now listen, this is the drug we have taken by oral route. So drug is going inside. I told you, learn the golden rule. For absorption, same pH is required. If the drug is acidic, you require acidic medium to absorb. And if the drug is basic, you require basic medium to absorb. So we know this rule. I mean, for absorption, same medium is required. Stomach have acidic medium and intestine have basic medium. That's why acidic drugs are absorbed from acidic medium. And that's why basic drugs are absorbed from basic medium. So this is the first rule. Ultimately, acidic or basic, the drug reaches in the blood. Drug reaches in the blood. So for absorption, we have two different organs. One is stomach, one is intestine. Now drug move to its site of action, already shows its mechanism of action, move to the liver, already converted from non-polar to polar. Now I want to excrete the drug. I want to excrete the drug from the kidney. But organ of excretion is only one, that is kidney. For absorption, I was having two options, two different organs. Stomach and intestine. But for excretion, we have only one organ, kidney. We don't have different organ that acidic drugs are excreted from this organ, basic drugs are excreted from this organ. No, no, no. Both the drugs are excreted from kidney only. In the kidney, the urine is formed. है ना? The drugs are excreted in urine, but the pH of urine can be changed. है ना? So for excretion, opposite medium is required. So if you want to excrete acidic drug, make the urine basic. And if you want to excrete basic drug, make the urine acidic. So for excretion, opposite medium is required. How many of you got it? So this is the basic rule. So learn the basic rule. For absorption, same pH is required. And for excretion, opposite pH is required. This is the first funda. You get many simple questions on that. Let me more twist it and tell you one more thing here. Listen, what is ionization? This is an acidic drug. HA. It can be HCl. It can be HNO3. I mean to say all acids have a proton. We know. है ना? Acid. HCl, HNO3, H2SO4. So all the acids have a proton. That is H. So it's split. It split or ionized like H positive and A negative. So where is the drug? इस पूरे में drug कहाँ है? Where is A? A is our drug. H तो proton है. H is proton. Where is the drug? I'm asking you. Where is the drug? Let me show you the drug. Drug is present in two forms. है ना? HA and A negative. So this is known as unionized form. There is no charge on that. And this one is known as ionized form. There is a charge on that. So A is present in two form. है ना? Same C with the bases. This is a base BOH. It can be NaOH, KOH. All the bases have a hydroxyl ion. We know the rule. है ना? It will split like B positive and OH negative. So I am interested in B. B is my drug. So where is the drug? Can you tell me where is the drug? Drug again present here. It is unionized. It don't have charge, and this is ionized. It have the charge. So acidic drug and basic drug both are present in two form, unionized and ionized. Unionized is complete. Unionized is this one. This is complete, and ionized are the splitted version. They are broken down. They are splitted. They are ionized. Now there is a rule. Body do not like the broken one. It excrete. So ionized form are excreted from the body, and unionized forms are absorbed from the body. So please learn, please learn. Unionized, these two will be absorbed, these two will be excreted. So please learn. Unionized are absorbed and ionized are excreted. How many of you got it? If you got this funda, the two golden rules, everything is super simple. Please read it. Please, everyone on the screen, see what I'm telling you. See, so if the drug is acidic, okay, so it will be absorbed from acidic medium, that is stomach. Absorption के लिए same medium is required. Because why it is absorbed from stomach only? Because in acidic pH it is unionized. It is unionized. That's why it is absorbed. Basic drug are absorbed from basic medium, that is intestine. But why? Because in basic medium it remain unionized, and unionized form are absorbed. We know that. The same you can apply for excretion, है ना? Acidic drugs are excreted in opposite, है ना? For excretion, opposite medium is required. So acidic drugs are excreted in basic urine, है ना? So why? Because in basic urine they are ionized, and ionized form is excreted, and basic drugs are excreted in acidic urine, because in acidic urine they are ionized. So ionized versions are excreted and unionized versions are absorbed. Everyone, each and every student, person who is live and understood this concept, give a gesture, give a thumbs up. You got it, or write down that you got it. Do you have any confusion? Any confusion? This is the effect of pH, the golden rule. Write down the golden rule of effect of pH on the absorption and excretion of the drug. Now you are going to get many questions on that. Repeatedly many questions are asked. No, you will get one question only, but one question matters. But frequently asked question, it is one of the frequently asked topic. And students always have confusion whether we want to absorb the drug or we want to excrete the drug. We want both. If sometimes to treat the patient we have to absorb the drug. Sometimes to save the patient in case of poisoning we want to excrete the drug. So if you want to excrete the drug, you have to acidify the urine or basify the urine. For example, in front of me I am a doctor and I am in a casualty in emergency duty, and there is the patient in front of me. The patient, he's a young boy, he's a teenage boy. And the patient is on stretcher, unconscious. The family is carrying the patient to you with a panic situation. The parents are there and they are saying, doctor, my son tried to do the suicidal attempt. Okay, kindly save him. Kindly save him. So the first question I will ask, to tell me the drug, which drug he have overconsumed. Okay, the poisoning is of which drug. So they will show you the empty strip, or they will tell you the name. Mostly it may be a sedative, tranquilizer, neem ki goliyan, if it is a suicidal attempt. So they will tell you the name of the drug, or sometimes it can be atropine or any drug. So you should know which drug is acidic or which is basic. It's the emergency situation. If the drug is acidic, if the patient have consumed over acidic drug, immediately basify the urine so that it excrete out of the body. And if the patient have consumed acidic drug, basic drug, over consumption of a basic drug, immediately acidify the urine. So the next question you may be thinking, ma'am, is it possible to change the pH of urine intentionally? Yes, we can do so. According to your choice, you can do so. है ना? So how to acidify the urine and how to basify the urine? If you want to acidify the urine, we will give IV drip of arginine hydrochloride followed by ammonium chloride. Arginine hydrochloride followed by ammonium chloride. We will give IV drip. So urine will get acidic to excrete the basic drug. And if you want to basify the urine, है ना, give a IV drip of sodium bicarbonate. You know soda bicarb, sodium bicarbonate, NaSCO3, है ना? So it is a basic medium. So it will basify the urine. So this is for excretion of acidic drug. So you want to excrete acidic drug, basify the urine. If you want to excrete basic drug, acidify the urine. This is the funda. How to know that which drug is acidic and basic? So there is a list given. So Ravijay. So there is a list. We have to learn that list. Being a doctor, we should know which drug is acidic, which drug is basic. So, you know, there are thousands of drugs. Learning all of them, which is acidic or basic, it's not an easy job. But for the main drugs which are used for the suicidal attempts, we should know the list. For the emergency, you know, drugs, you should know which is acidic and which is basic. So it is the nature of the drug. So that is acidic or basic. So that you have to learn. Uske liye koi formula nahi hai. ठीक है? So this is the rule. Everyone got it? Everyone got it? So this is the rule. We will solve some questions and move on the next topic. Read the question and tell me the answer. Okay. Acetyl salicylate and phenobarbital. You know, acetyl salicylate and phenobarbital. Phenobarbital is barbiturate. It's a sedative. Okay. नींद की गोलियां हैं. Are better absorbed from the stomach. Why? It is not asked if they are better absorbed from the stomach. They are giving you that it is already, they are giving you the information. The examiner is telling you that these two drugs are absorbed from the stomach. Why they are absorbed from the stomach, not from intestine? Why? Can you tell me the reason? Can you tell me the reason? First, you decide these drugs are weak, strong or weak. So I told you strong acid or base are non-electrolyte. They are not ionizing. Their absorption and excretion do not depend on pH. So remove the option containing strong. Now the three option with weak. है ना? Now stomach में कौन सा medium होता है? Stomach में कौन सा medium होता है? Stomach में medium is acidic. And we are talking about absorption, not excretion. So for absorption, same medium is required. For absorption, same medium is required. So in the stomach, we have acidic medium. So acidic drugs are absorbed from acidic medium. So of course, it's going to be a weak acid, not a weak base. So in the weak acid also, we are having two options. It will remain non-ionic or ionic. I told you, body want the complete drug. The splitted version is excreted. I want to retain. I want to absorb. So I want the non-ionic drug. So correct answer is A. How many of you got it? So this is the approach for this question. Now, if you don't know the golden rule, you cannot solve this question. This question is considered to be difficult level. There are 3 level questions, easy, moderate, difficult. I will put it in difficult category if you don't know the formula. But if you know the golden rule, I told you the golden rule. This is the golden rule. Okay, if you know that, this question is going to be simplest for you. Say yes, everyone. Got it? Got it? If you got it, can I go ahead? No. These are not strong acids. These are the weak acids. Strong acids नहीं है ना? The complete funda, ये जो golden rule है, it belongs to weak drugs, weak electrolytes, weak acid and weak base. This is not for strong. This golden rule is not for strong because strong electrolyte absorption and excretion is pH independent. They are absorbed in acidic also, basic also equally. The strong one, but weak one have a preference. So this is the preference of the weak one. Weak acid have a different preference. Weak base have a different preference. But strong acid and strong base don't have any preference based on the pH. I hope my concepts are crystal clear. Can we go ahead? Can we go ahead? Few more questions based on this topic as the topic is important and difficult. Can you read the question and tell me the answer? Acidic drug is more ionized at. Now use your brains. Tell me. They are asking for acidic drug. In ionized form, drug is absorbed or excreted. Ionized matlab splitted version. Ionized meaning is it's splitted. It's ionic. It's have a charge. So the splitted version body do not want to retain. Body want to excrete the charge. So we want the excretion. It means the examiner want to ask you acidic drugs are excreted in which medium. So is it alkaline, acidic pH, neutral pH or none? So for excretion opposite pH is required. So they are talking for acidic. Go with basic. So I will go with A. So I hope you got it. This is the approach. Okay. Instead of reading the word ionized, read the word excretion. Read the word excretion. So acidic drug more excreted at which medium? So this is the meaning of the question. Okay, one more question. About acidic drug, what is true? Tell me a weak acidic drug. What is true? It is best absorbed in acidic medium. Acidic are absorbed in acidic. Is it true or not? It is best absorbed in alkaline medium. Is it true or not? It is not absorbed in acidic medium, or it binds to alpha glycoprotein. What is correct? So I told you, for absorption, same medium is required. And for excretion, opposite medium is required. So currently we are talking about absorption. Absorption, best absorbed. So acidic drug absorbed from acidic medium. So correct answer is A, and I hope you all are right. Okay, correct. So one more last question. What is the best way to manage a patient who is a poisoning case? It's an emergency case with aspirin poisoning. First you decide aspirin is an acidic drug or basic drug. First you decide. Do you know? I will tell you otherwise. First you give a guess. If aspirin is an acidic drug, make the urine basic. And if the aspirin is a basic drug, make the urine acidic, because you want excretion. Now, nobody is telling you कि excretion कराओ, but it's your common sense that you are using कि मैम poisoning का case है, तो we don't want absorption. Poisoning का case है, तुमने और absorption कराया तो patient will die. I do not want to kill my patient. It's poisoning. I want to excrete the drug. There is a patient in front of me. The stomach and intestine is full of drug. He has already overtaken the drug. I want to excrete it. I do not want the drug to get absorbed. I want to excrete it. है ना? So excretion के लिए I want to make the pH urine opposite. है ना? So you tell me aspirin क्या है? Aspirin acidic है कि basic है? Aspirin is an acidic drug. If it is an acidic drug, you have to basify the urine. For alkalinizing or basifying the urine, we have to give IV drip of sodium bicarbonate. Instead of aspirin, if I give you any acidic drug, any basic drug, in that case, your answer will become A. You have to acidify the urine in that case. Okay, so this is the funda. Got my point, everyone? Can we go ahead? The next question in front of you. Alkalinization of urine is done for. When we do alkalinization of urine को alkalinization मतलब basifying. When we basify the urine, we want to basify the urine. Why? We want to excrete what? We want to what? It is not for strong. I told you, strong acids and strong base. The strong electrolytes, they are pH independent. So the question lies only on two options. You should have a close differentiation between the two options, weak acid or weak base. So for excretion, we require opposite medium. So we are basifying the urine for acidic drugs. So again, the correct answer is A. So this is the funda. Okay, coming on the next topic. I hope you got it very well. Coming on the next topic is bioavailability. What is bioavailability? See here. Everyone see here. So can you see this is a drug? Again, we are taking it by oral route. The drug is going inside, getting absorbed. Acidic drug from acidic medium, basic drug from basic medium, we got it. Ultimately, the drug reaches in the circulation. Sometimes this drug, not every time, most of the time it's active, but sometimes it is inactive. It is a prodrug. So it will go to the liver. Okay, no. ठीक है. Prodrug, I will tell you later on. So it is reaching to the circulation. Got it? This is how it is reaching to the circulation. So if I have given 100 gram of the drug orally, how much gram is reaching to the circulation? Maybe in the circulation only 70 is reaching, 80 is reaching, 90 is reaching, but it's never 100 by a oral route. Oral route is never 100%. Whatever you are giving, it is not 100% absorbed. So that is bioavailability. Bioavailability is the percentage of the administered dose. Whatever dose you are giving in the administration, what percentage is reaching the circulation, that is bioavailability of the drug. Got my point? So what is bioavailability? What is bioavailability? It is the percentage. It is a fraction of the administered dose. Whatever dose you are administrating in the patient, it is a fraction of that reaches the circulation in unchanged form. Now, I would like to modify this diagram. I guess you have read this. Listen. Again, start from the beginning. The patient is taking the drug from mouth. It is going inside. Before going here in the blood, do you know the intestine drainage? From the intestine, there is a portal vein. The portal vein is there, which goes to the liver, which shunt the blood. The intestinal blood, the intestine vein, mesenteric vein, it will drain to the portal vein, and first it will go to the liver. From the liver, it will go to the heart, the right side of the heart. From the right side of the heart, it will go for purification here in the lungs. From the lungs, it will come to the left side of the heart. From the left side of the heart, it will come in the aorta and then come in the blood. This is aorta. That is circulation. So it is coming to the aorta via liver. In the liver, certain enzymes are present. Certain enzymes. You may be thinking, ma'am, why 100% drug is not reaching in the circulation? You are saying that whatever percentage of drug you are giving, for example, I am giving 100 gram. So I am saying it's never 100 which reach here. Never. Maybe it is 99, but never 100. It is never 100. It can be less than 100 via oral route. So why it is less than 100? Tell me the two reasons. Why it is always less than 100, never 100%. It is bioavailability. The definition of the bioavailability is the percentage or the fraction of the administered dose which is reaching unchanged into the circulation. So there are two reasons. The first reason is the absorption. So absorption is not complete. Sometimes it is not completely absorbed. Whatever dose you are giving, absorption may ही problem hai. Sometimes there is disease in the stomach. Sometimes the stomach is full with the food. Sometimes some inhibitors are present in the food. So absorption is not complete. So first reason, it is absorption. Absorption is not complete. Number one. And whatever is absorbed, uske baad, it is going to the liver via portal circulation. In the liver, certain enzymes are there that will deactivate the drug. Uske baad jo bacha phucha, the remaining portion which is coming, that is the drug actually will show its site of action, its mechanism on the site of action. So that is going to be show its mechanism of action. Got it? So bioavailability reduce hone ke two causes hai. What are the two reasons you got it? Number one, absorption. Absorption is not complete. Number two, first pass metabolism. First pass metabolism is the liver. So drug from the stomach or intestine first go to the liver and then go to the heart and then come in the circulation. So in the liver, the enzymes is doing the degradation of the drug. So that drug will be inactive. That portion of the drug will be inactive. So for example, I am giving 100 gram last time. I am giving 100 gram of the drug, out of which only 80 is absorbed. So 80 reach here, 80. Now this 80 will go to the liver. In the liver, further 10% is degraded. So 70 will come back. So out of 100, only 70 is coming. 20 is lost in absorption and 10 is lost in the portal circulation. You got my point? First pass metabolism. So whatever after that it is reaching the circulation, ultimately that is bioavailability. How many of you got it? How many got you? How many of you got it? So the two reasons. So the percentage may vary. It is not always 20% lost in absorption and 10% lost in portal circulation. The percentage can vary. So but it is never 100% unchanged reach in the blood. So it is not oral route. No, always we give the drug. We give the drug by various route. So 100% bioavailability occur in only one route, IV. If I'm giving the drug directly in the blood, IV, there is a vein here. So if I'm giving it directly intravenous or intra-arterial, directly in the blood, if I'm directly giving in IV, so 100%, I'm having 100 gram, 100 ka 100 IV. By whatever else route I'm giving, it is never 100. So 100% bioavailability occurs only in IV, because I'm having 100 gram, all the 100 gram is injected. So 100 ka 100 is in my blood, unchanged, without lost in absorption, without lost in first pass metabolism. In all different routes, it is less than 100. It is less than 100. Got it? So that is bioavailability. You got my point? How to calculate the bioavailability of a drug? How to calculate the bioavailability of a drug? Is there a way? Just suppose I have a drug. This is drug A, and I'm giving you an experiment. Can you please find out the bioavailability of this drug in humans? If I give this drug to any human via oral route, can you tell me the bioavailability? You say, ma'am, how to calculate? So we have an easy way to calculate. Make a graph. You have to make a graph between two things. This is x-axis of the graph. This is y-axis of the graph. So in a graph on the x-axis, just suppose I have taken a tablet by mouth, by oral route. This is 0. So as it will go inside, it will get absorbed and it will reach in the blood. So the concentration in the blood, it will increase gradually. On x-axis, take the time. And on y-axis, take the plasma concentration of that drug in the plasma, in the blood. So as the time increases, in 1 hour, 2 hour, 3 hour, 4 hour, 5, so in my blood, it is getting absorbed. In my blood, the concentration increase. One time will come, it is maximum absorbed. So this is the maximum plasma concentration. After that, it will show its mechanism of action and get excreted in the urine. Then its concentration fall, and one time will come, it will become 0. So this graph is the graph of plasma concentration versus time. If you take the area of this graph, and it is looking like a triangle. You know what is the formula of triangle area? It is half into base into height. You may have read this in mathematics. So half into whatever is the shape. I'm not interested in mathematics, but whatever is the area under this curve, that will give you the value of bioavailability. So bioavailability is the area under curve. It is known as AUC. What is area under curve? Which curve? The curve is between two things, plasma concentration and time. So make a graph. What you have to do? You have to make a graph between time and the plasma concentration of that particular drug. I'm having a drug A with me. So I will take a subject. There is a subject in front of me. I will ask that subject to keep the tablet in the mouth, take it with the water. So every 1 hour or every half hour, I will take the plasma concentration. I will take a blood sample and check the plasma concentration of the drug. So this is the time 0. So I will check it at 1 hour, 2 hour, 3 hour, 4 hour, 5 hour, 6 hour, 7 hour. And this is the plasma concentration 10 milligram, 20, 30, 40, 50, 60, whatever. So I will find that gradually the plasma concentration is increasing because drug is absorbed. Acidic from the stomach, basic from the intestine. Absorbed. It will reach the maximum and then it is excreted, finally becomes 0. So area under this curve will give you the value of bioavailability. It is known as AUC. How many of you got it? This is AUC. ठीक है? Got it? है ना? Sublingual में it will be better but never 100. The point is that it will be never 100. 100 only in IV route. In all other route it is less than 100. Got it? Okay, so this is area under curve. See the x-axis and see the y-axis. And this is area under curve. Area under curve. This will give you the value. Now I have one drug, again the same drug, drug A. I'm having two different subjects. This is a subject, this Ram Sham. I'm having two subjects. So this patient, this subject, I'm giving it by oral route and checking the bioavailability by making a graph. So this is the graph of Ram. I mean the patient, the subject in which I'm giving it by oral route. And the same drug, drug A, I'm giving to Sham by IV route. Directly I'm injecting. So this is the curve in the other patient in which I'm giving it to IV. So same drug, you can see. Now calculate this area. This is the area. And calculate this area, which already includes this one. So calculate this area. So obviously you can see the area of IV is more than oral. In IV it is 100%. In oral it is never 100. So this is how we can calculate. Got it? Say yes. I will come on the half-life also. Wait a while. It will be in a sequence. Come on. Wait. Have patience. Okay. Got it? Run Vijay. Wait a while. I will come on all the topics. Okay? So this is area under curve. So you get questions on the bioavailability. Please, I have not put the question, but you get question on the bioavailability. You can get this curve in your exam and they can ask you the labeling. Which is red or blue? Which of them is showing the oral route? Which of them is showing IV route? They can ask you this question. They can ask you the labeling. They can ask you what is there on the x-axis, what is there on the y-axis. They can ask you what the area under curve is presenting. So multiple questions can be framed from this graph. Got my point? Give me a thumbs up. Can I go to the next topic? My next topic here to explain you in pharmacokinetics and absorption is prodrug. Can I explain you what is prodrug? Say, what is prodrug? Listen, everyone here, listen. This is the drug I'm taking by mouth again. So drug is going inside, getting absorbed. Acidic from the acidic medium, basic from the basic medium. It reaches in the circulation. Now I want that this drug should go to the site of action and shows its mechanism of action. This should happen. But unfortunately, this drug is inactive right now. It cannot show its action. Not all drugs are inactive. Some drugs are inactive. These drugs are known as pro matlab inactive. These are prodrugs. So you will say, ma'am, how they will become active now? How they will show their mechanism of action? So first this drug should move to the liver. In the liver have the enzymes that convert the inactive drug to active drug. And after that, it should come to the blood again and then go to the site of action. Okay, so these drugs are prodrugs. So first they should go to the liver and convert from inactive to active. And then it should go to the site of action. Say yes if you got it. So these drugs are known as prodrugs. You should know the list of the prodrugs. You should know. But if they go to the liver, you should think, ma'am, liver mein to deactivating enzymes are also there, na? First pass metabolism. If you are saying drug first go to the liver, getting converted from inactive to active, got it. But the active version will get degraded because of the biometabolism, because of the first pass metabolism. Yes. So prodrugs are not supposed to be given via oral route, na? Most of the time, because bioavailability will reduce. That's it. Okay, got it. And after that, the drug is supposed to go to its site of action. So give a list of the prodrug. What is the list of the prodrug? So I'm having a mnemonic for you. The mnemonic is in front of you. You can see the mnemonic. The mnemonic is in front of you. All prefer doing MD in clinical subjects. You also prefer to do MD in clinical subject. So there are many mnemonics in pharmacology. If you wish, I will give you all the mnemonics at one place at one PDF. But first, understand the complete pharma. After the first and second, both my session, I will provide you a mnemonic PDF also. In which all the complete pharma mnemonics will be at one place. Nearly 30-40 mnemonics are there and you can revise them before going your exam. Okay, or maybe more than that. Okay, anyways, come here. So prodrugs. What is the mnemonic for the prodrug? It is in front of you. A stand for ACE inhibitor. What are ACE inhibitor? Pril. All the drugs which have a suffix of pril, they are ACE inhibitor. So all the ACE inhibitor are prodrug except two. Captopril and lisinopril. Captopril and lisinopril are ACE inhibitor, but they are not prodrug. They are not prodrug. The second is P. P say we are having three drugs: prednisolone, proton pump inhibitor, and proguanil. D say we have only one drug, dipivefrin. M say we have three drugs: mercaptopurine, methyl dopa. It is dopa, methyl dopa. है ना? We give it in Parkinsonism, and minidoxal. D say we have levodopa. So we have levodopa, we have methyl dopa. Levodopa we give in this Parkinsonism. I say we have irinotecan. C say cyclophosphamide, clopidogrel, carbamazine. And S say sulfasalazine. It's an antibiotic. Okay. So all these drugs are prodrugs. So you don't mug up the list, learn the mnemonic, read it 2-3 times. In the option, you will be able to identify it. So all, prefer, doing, am, D, in, clinical, subject. So this is my mnemonic. From the P, I'm having 3 drugs. C, I'm having 3 drugs. Likewise. So you have to learn the full form. Say yes if you all got it. Say yes if you all got it. Can we go ahead? Got it? So can we go ahead? I will come on that biotransformation, Nadeem. I'm coming. My next topic is biotransformation only. So you can solve this question. All are prodrugs except. So tell me which of the following is not a prodrug. Is it aspirin? Is it levodopa? Is it dipivefrin? Is it captopril? So I told you all ACE inhibitors are prodrug except 2. That is captopril and lisinopril. So examiners love exception. Jahan pe bhi exception hai, please learn it. Please learn it. Okay, can we go ahead? Are you learning, enjoying, understanding the lecture? Pharmacology is very conceptual if you understand it. Okay, so can we go ahead? Okay, give me a minute. I just want to have a sip of water. Thank you. So we will move to the next topic, that is metabolism or biotransformation. So what it means, I told you. So this is a drug taken by oral route. After going inside, it got absorbed. It got absorbed from the stomach and intestine. It reached in the blood. From the blood, it goes to its site of action. Already shown its mechanism of action. Its job is done. In the body, its responsibility, its job is done. Now the body wants to excrete it in the urine. So the drug is entering in the kidney and asking the kidney, can you please excrete me? My job is done. The kidney is saying, no, I cannot excrete you because you are a non-polar drug. First go, get converted into polar, then come back to me. Because from me, if you get excreted from the kidney, it will be in the form of the urine. Urine is water. Only water-soluble drugs are excreted. Non-water-soluble drugs are not excreted in the urine. So first become water-soluble. You become polar. Polar is water-soluble. So convert from non-polar to polar. So what the drug will do? Drug will go in the liver. Asking the liver, can you convert me from non-polar to polar so that I can excrete out? Liver will say yes. Come inside me. Inside me there is hepatocyte. Inside the hepatocyte, there are certain enzymes. The most important enzyme is cytochrome P450. This enzyme will convert the drug from non-polar to polar. So the drug is entering here, getting converted from non-polar to polar, coming back to the blood and then entering in the kidney. And once it becomes polar, now it is easily excreted out. So this conversion is known as biotransformation or metabolism. Okay, got it. This is biotransformation or metabolism. So what is the definition? There are 3 definitions. Non-polar to polar. Biotransformation is conversion of drug from non-polar to polar, or hydrophobic to hydrophilic. Hydrophobic, hydro matlab water, phobic matlab insoluble, to water soluble. Hydrophilic, I guess everyone know phobic and philic. Phobic means insoluble, phobia, insoluble, and philic means soluble. So I want to make the drug from non-polar to polar. The meaning is the same. Instead of that, you say hydrophobic to hydrophilic. This may be your option. Instead of that, water and lipid are inverse. So the thing which is water soluble is lipid insoluble, and the thing which is lipid soluble is water insoluble. So instead of that, you can say lipophilic to lipophobic. Lipophilic. Yes, lipophilic to lipophobic. So I want to convert the drug from lipophilic to lipophobic. Whatever option given to you, that is right. So you have to search for the option. They can ask you a definition. What is biotransformation? Look for this option if it is there. Look for this option if it is there. Look for this option if it is there. Whatever is there, that is correct. One of them will be there. They will not give you all of them. Say yes, got it. So sometimes you learn only this definition, but in the option, they just confuse you by giving these definition and you get confused. What is this? So you should understand these definitions also. These are the simple things. The meaning is the same. So that is, we are converting a non-polar drug to a polar drug in the liver. Most of the time it is happening in the liver. Rarely it is happening in other organ, but most of the time it is happening in the liver. So you will say, ma'am, how? Tell me the exact mechanism. How does a non-polar drug get converted into polar? So there are two phases, phase 1, phase 2. Phase 1 is known as functionalization. Phase 2 is known as conjugation. Let me explain. In both of them, it is happening in the liver. So ultimately, let me draw the liver on the next page. In the liver, non-polar drug getting converted to polar. So I'm having two options. How I convert a non-polar drug to polar? Imagine this is a non-polar drug and this is also a non-polar drug. I want to convert into polar. So in the first phase 1, and this is phase 2. In the phase 1, what I will do inside this drug, inside the structure of this drug, there are certain functional groups. I will expose that functional groups like hydroxyl group, amino group, sulfur group. So many functional groups are there. Because of exposure of these functional groups, the drug will get converted from non-polar to polar. So when these functional groups were hidden, the drug was non-polar, but once I have exposed them, it will convert into polar. So phase 1 reactions are known as functionalization because here the functional group is exposed, and by this mechanism I am converting the drug from non-polar to polar. This is phase 1. In phase 2, this is the drug. Again, it is non-polar. Here what I am doing, I want to convert it into polar. So what should I do? So say here we will take another substance, another endogenous substance in the body. This is polar. I am saying drug is non-polar, but this substance is polar and I am combining the drug with this substance. This substance is polar. So what I am doing, I am combining this drug with a substance which is polar. With a polar substance. It is an endogenous substance and I'm making a conjugate of the two. The two will combine together and they will make a couple. They will make a conjugate. So this is the drug and this is the endogenous compound which is polar. So the combination of the two is polar. So this was non-polar, this is polar, but the combination of the two will become polar. Such reactions are known as conjugation reaction. We are conjugating the drug with something. So phase 2 reactions are known as conjugation. How many of you got it? So phase 2 reactions are known as conjugation. So with which compound, with which polar compound you are conjugating the drug? There are 6 options. In the body, there are 6 options. Glucuronide, the most common, it is known as glucuronide conjugation, glycine conjugation, glutathione conjugation. So 3 of them are GGG. Glutathione, glycine and glucuronide. Glucuronide is most common. Apart from that, SMA, sulfyl, methyl and acetyl. You combine it with sulfyl group, methyl group, acetyl group. You can learn a mnemonic GGG, SMA. So there are 6 types of conjugation. In the functionalization, you want to expose the functional groups. So you have 5 options. Here we have 5 options. You can do the oxidation, you can do the reduction, you can do the hydrolysis, you can do the cyclization and decyclization. By these 5, you can convert a non-polar drug to polar via exposing the functional group. And by these 6 options, you can convert a non-polar to polar drug via conjugation. So the summary is that I am teaching you biotransformation. What I am teaching you? Biotransformation. Biotransformation takes place in liver, in which a non-polar drugs convert into polar, and it is of 2 types. Type 1, that is functionalization, and type 2 is conjugation. In both of them, thing is same. Non-polar convert into polar with the help of functional group exposure. Here also non-polar get convert to polar with the help of conjugation with a polar endogenous compound. This one is of 5 type, this one is of 6 type. Give me a thumbs up, I tried my best. Say yes. So the same thing is written in front of you. This is type 1. You can see. This is type 1 in which we will expose the functional group and convert it from non-polar to polar. It is of 5 type. Oxidation, reduction, hydrolysis, cyclization, decyclization. And phase 2. Phase 2. Here also I am doing the same. Here also non-polar to polar. Here also non-polar to polar. But here the mechanism was exposure of functional group. And here the mechanism is conjugation, coupling or conjugation with the endogenous polar compound. So it is of 6 type. What is 6? GGG, SMA. It is glucuronide, glycine, glutathione, sulfate, methyl acetylate. Say yes, people. Got it? Endogenous मतलब body के अंदर ही है वो, बाहर से नहीं दे रहे, है ना? Ranvijay, I'm not giving it from outside. Endogenous is inside my body only. So all these compounds are the metabolites present in my body only. They will combine with the drug. They are already present in the liver. Already there in the liver as the metabolite of some other metabolism. So they will combine with the drug and convert from non-polar to polar. Say yes. Among them, now you should know example of all 11. So phase 1 mein there are 5. And phase 2 mein there are 6. Ideally you should know the examples that which drug is excreted by which mechanism. Which drug is metabolized by which mechanism. But most importantly, questions are asked on acetylation. Acetylation में बहुत question आता है. You frequently get question on the acetylation. So learn the list of acetylation here I am giving you. So which drugs are excreted by acetylation? So this is the list. So again I am having a mnemonic for you. The mnemonic is CHIPS ABC. What is the mnemonic? The mnemonic is in front of you. The mnemonic is CHIPS ABC. What is the mnemonic, people? क्या है mnemonic? It's CHIPS ABC. No, what, I cannot read your name. Sucklane. No, it is not always phase 2 is followed by phase 1. Sometimes it may happen. Sometimes even on conjugating, the drug didn't completely convert from non-polar to polar. So phase 2 is followed by phase 1. Ultimate purpose of the body is that we want to convert non-polar to polar. Okay, so it is not always phase 2 is followed by phase 1 or phase 1. Ultimately, jab ho gaya to waisa. It is not always. Maybe only phase 1 is required, maybe phase 2 is required, maybe both is required. Got it? Chalo. So CHIPS ABC. What is CHIPS ABC? It is the acetylation. These are the list of the drugs which are metabolized by acetylation. So what does C stand for? It is clonazepam. What is clonazepam? It is a zepam. It is one of the sedative. Okay. What is H? Hydralazine. What is hydralazine? It's the antihypertensive drug because it is the arteriodilator. It is a vasodilator. It dilates the artery. Isoniazid, everyone know. It's the anti-tubercular drug. Okay. Dots में use करते हैं. Procainamide, it's the anti-arrhythmia drug. Sulfonamide, it's one of the Dapsone. It's an antibiotic. Is butanol, it's one of the beta blocker. And a benzocaine and caffeine. So please learn. CHIPS ABC. You can learn. So it is CHIPS ABC. CHIPS ABC. Say the full form. Full form is important. Okay. Please learn the full form. You get questions on that. Read the question and tell me the answer. Frequently asked question. So I'm covering all the frequently asked topics here in this rapid revision, which are frequently asked in the exam. Okay. All the drugs are metabolized by acetylation except, I'm asking except, use your mnemonic. CHIPS ABC. CHIPS ABC. So what is not coming? Hydralazine is coming. Yes, of course it's coming. Isoniazid is coming. Of course it's coming. Now, the catch in the question. What is this P? What is this P? If you learn only mnemonic and you don't learn full form, you are in trouble. If you learn only mnemonic, not the full form, you are in double trouble. Okay. What is this P? P is phenytoin or procainamide? What is this P? If you don't know, you will bluff. So the mnemonic include procainamide. You can see procainamide is there, but phenytoin is not there. So my answer is phenytoin because they're asking the except. So correct answer is phenytoin. So that is the thing. Can we go ahead? Now, the story is not over. Metabolism. Let me tell you the climax of this metabolism. Okay, it's difficult. So inside the liver, I told you, na, this is the liver. Where is my diagram? This is the liver. Inside the liver, hepatocytes are there, and inside the hepatocytes, enzymes are there, which convert the drug from non-polar to polar. Okay, enzymes are of two types. These enzymes are of two types. Microsomal and non-microsomal. Microsomal are the enzymes which are present in endoplasmic reticulum. Most common example is cytochrome P450, which is very dangerous enzyme. And the enzymes which are present in cytoplasm, they are non-microsomal. So the problem is that these enzymes are inducible. They can be induced or inhibited by other drugs. But these enzymes are non-inducible. Microsomal are inducible. That's why they are dangerous. They are dangerous. But non-microsomal are non-inducible, non-inhibited by other drugs. Let me tell you. Let me explain you. Okay? So I will explain you microsomal enzymes, which are ultra dangerous. Okay? Being a doctor, you should understand it very clearly. So microsomal enzymes, I will tell you two things. The induction and inhibition. See, please understand. Imagine you are a doctor and you are giving some drug to your patient. For example, your patient is having only one disease. You are giving only one drug for that. This is that drug. So drug going inside, getting absorbed, showing its mechanism of action. Now that drug want to get converted from non-polar to polar. So it is entering inside the liver. That is entering. On the next page, I am showing the zoom version of the liver. I have zoomed the liver to explain you the induction. See, this is the liver. This is the liver you can see. Okay. Inside the liver, you can see this is the hepatocyte I have drawn. Inside the hepatocyte, this is the endoplasmic reticulum I have drawn. Inside which the enzyme is there. Can you see this is purple color enzyme? This is microsomal enzyme. Most common cytochrome P450. It can be any microsomal enzyme. You can see this purple color. So see the liver, see the hepatocyte, see the endoplasmic reticulum, inside which this enzyme is there, microsomal enzyme. Now you are a doctor. Now you are giving only one drug, drug A to your patient. The story was very simple. This drug was going inside the liver. Liver, please can you convert me from non-polar to polar? Happily liver was saying, yes, come inside me, I will convert you. The drug was going inside, getting converted from non-polar to polar, and happy, it was getting out and getting excreted out of the kidney. The things were super simple simple. Everyone was happy. But let's complicate it. Let's complicate it. You never give one drug to your patient. है ना? Patient एक complaint के साथ नहीं आता. Doctor headache भी हो रहा है, acidity भी है, fever भी है. You give a multiple drug to your patient. Okay, you take this also, this also, this also, this also. So drug-drug interaction is there. Got it? So you give multiple drug. Now you are giving two drug, for example. So this is drug A, which you were giving previously also, and now you are giving it with drug B. Drug B. What is drug B? Drug B is enzyme inhibitor. See minus. I have drawn minus. Minus means it is inhibiting this enzyme. Inhibiting. This enzyme is inhibited. Hana? So B is the inhibitor. Okay. Now what will happen? This drug will come inside the liver. Liver, can you please convert me from non-polar to polar? I want to get excreted. Liver is saying no, I cannot convert you because the enzyme inside me is gone. There is another drug in the body, drug B, that hit my enzyme, that has inhibited my enzyme. Now I don't have enzyme, so how can I convert? No, you go back, I will not convert you. So this drug will it will not convert from non-polar to polar, it will remain as non-polar only. So it will not excrete it from the body. It will remain in the blood only and it will produce toxicity. So when you were giving A alone, the things were simple. But when you are giving A with the B, the A have a toxicity. So this is the reason, because B is the inhibitor. How many of you got it? So I will call the drug A. I will call the drug A as substrate drug or parent drug. Substrate drug या parent drug. And I will call the drug B as inhibitor drug. So I will suggest you, being a doctor, you should know this combination and you should avoid this combination. Never give a substrate with the inhibitor. If you do so, the substrate have the toxicity, not the inhibitor. So this is the list in front of you. This is the substrate drug. This is the inhibitor drug. This is drug A. I have shown with red color in that diagram. And this is the B I have shown with green color in that diagram. Got my point? So toxicity of A occur, not B. So learn the list of the substrate and learn the list of the inhibitor. Being a doctor, never give them together. So it is not the patient, it is the doctor's responsibility. Whatever drugs you are prescribing, before giving it to the patient, check the combination. Is the combination is this one? No, don't give it. Because otherwise, if you are giving it substrate A, drug will have the toxicity. And you know the reason behind that. How many of you got it? Huh? So what is the mnemonic of the substrate? In the substrate, I am having a mnemonic. The mnemonic is CT scan. CT scan. C stand for cyclosporin and calcium channel blockers. T stand for tacrolimus. Okay? S stand for statins. C, one more C. It is stand for cisapride. A stand for amiodarone and estimizole. And N for Nevers. Nevers are the anti-HIV drugs. In the treatment of HIV, we use them. Never give along with what drugs? These are the enzyme inhibitors. Again, I'm having a mnemonic to learn that. The mnemonic is vitamin K cannot cause enzyme inhibition. V stand for valproate. K stand for ketoconazole. One more C stand for simantadine. One more C stand for ciproflox. E stand for erythromycin and I for isoniazid, that is TB. So imagine there is a patient coming to me who is having HIV, or who is having high cholesterol. For that the patient is on statin, or for that the patient is on Navrus, and the patient is having fungal infection also. I cannot give ketoconazole. To HIV patient who is having fungal infection. No. The combination is deadly. I hope you got it. Everyone, give me a thumbs up if you got it. So this is a deadly combination. You got it. So please don't do this. Now come on the enzyme induction. This was enzyme inhibition we have learned. Drug B was inhibiting the enzyme. Now drug A will induce the enzyme. Again the same story. Listen, again the same story. If I was giving A alone, things were very simple. A was going inside, happily it was converting from non-polar to polar, getting excreted out of the body. Things were super simple, things were happy. There was no complication. But there is a complication now when we will give the combination. In the combination, I am giving two drugs, drug A with drug B. The problem is that this B is inducing the enzyme. See the plus sign. It is not inhibiting, it is inducing. So the enzyme becomes hyperactive. In the previous case, it was inactive. Now it becomes hyperactive. You will say, ma'am, what do you mean by hyperactive? As soon as drug A enters in the body, it will metabolize it. वो बोलेगी नहीं कि मुझे करो. Drug A is not asking the liver. Basically, this drug A, I want this to first go at the site of action, show its mechanism of action, and then go to the liver. But here inside the liver, the enzyme become hyperactive by drug B. So before drug A go and show its mechanism of action, no. Before that only the liver is metabolizing it, non-polar to polar, and excreted out. So drug A का mechanism ही नहीं हो पा रहा. Before that only the liver is excited to liver is hyper excited. The enzyme of the liver is hyper excited to convert it from non-polar to polar because hyperactive enzyme is there. It is induced enzyme. How many of you got it? So in this case, it is not toxicity of A. It is decreased effectiveness of A. It is opposite of toxicity. In the previous case, A was showing toxicity. Here A is not showing its action. It is having decreased efficacy. How many of you got it? How many of you got it? Can we go ahead? Huh? कितनों को समझ में आया? It was a difficult funda. You got it? So here drug B, what the drug B is doing? Have a look here everyone. Drug B is inducing the enzyme. You can see the same enzyme. It is inducing. Inducing means the enzyme become hyperactive. So before drug A show its action on its site of action, before that only it is metabolizing A from non-polar to polar. Once it become polar, it will get excreted. So drug A is unable to show its action or showing less action. So here the consequences, the drug A will show reduced intensity and reduced duration. In the previous one, in case of inhibition, the consequence was drug A was showing the toxicity. Hana? So again, you should know the deadly combination. You should know not give this combination also, A and B, where B is inducing the enzyme. If you do so, A will not function. So the substrate drug remains same. The red one is same here also. Hana? The green one is changing. So here it is still CT scan. Here it is still CT scan. But inducers का mnemonic है GPRS, cell phone, battery dead. You have to learn mnemonics. Actually, in general pharmacology, there are many mnemonics. है ना? So G stands for rhizophlavin. It's the antifungal drug. P is phenytoin, anti-epileptic drug. R is rifampicin, anti-TB drug. ठीक है? S is smoking. Smoking is not a drug, but we are taking it here. C is carbamazepine, है ना? Carbamazepine. It's also anti-epilepsy drug. P is phenobarbital. B is barbiturate, which is phenobarbital only. And D is DDT. So again, never give them together. If you give them together, these drugs will not show their action. They will have reduced efficacy and reduced duration. I hope you got it. So basically, this is the summary. This is a summary. Never give this with this and this. Hannah, never give substrate drug with inhibitor also, with inducer also. If you are giving, Hannah, the substrate is same. If you are giving the substrate with inhibitor, the substrate will have toxicity. And if you are giving the substrate with inducer, the substrate will have reduced duration. So never, never, never give this combination. How many of you got it? There are many combinations. The current combination I'm telling you is this one. Hana? Inhibitors and inducers. Got it? It is not total. Pharmacology, there are more than thousands of combinations you have to learn. These are the most frequent which are asked in MCQs. Okay, G, everyone give me a thumbs up now if you got it. Respond people fast. Thoda sa fast respond karoge. Got it? So you got the 3 list. You get many questions on that. So learn the list of the substrate. Hana? Learn the mnemonic of the inhibitor. इनहिबिटर का क्या निमोनिक है? विटामिन के कैन नॉट कॉज एंजाइम इनहिबिशन. देखो इनहिबिशन से याद आएगा इनहिबिटर. और इंड्यूसर का क्या निमोनिक है? जीपीआरएस, सेल फोन, बैटरी डेड. इंड्यूसर. सो प्लीज, है ना? अच्छा, वन मोर मैकेनिज्म इज देयर. The third, apart from inducer, apart from inhibitor, the third mechanism is Hoffman's elimination. Listen, this is a drug. Drug is going inside, getting absorbed. Already shown its mechanism of action. Hana, the job is done. Hana, now this drug is very egoistic. The drug do not want to go to the liver. In the liver, the enzymes are there. Hana, enzymes want to help the drug. Yes, come inside us. We will convert you from non-polar to polar. But the drug is very, you can say, self-centered. The drug is saying, no, I would not take the help of the enzyme. I will convert from non-polar to polar, but myself, without the agency of the enzyme. So I will not go to the liver. Hana? So how this drug will convert from non-polar to polar? Hana? How it will convert without the use of the enzyme? Only one drug do so. So this drug will do certain changes in the molecular rearrangement in the 3-dimensional space and convert from non-polar to polar in the blood itself. It will not go to the liver. It will not use the enzyme. So without enzyme, without enzyme-free metabolism, only one drug do so. The mechanism is known as Hoffman's elimination and the name of the drug is etracurium. It's very important question, repeatedly asked MCQ. So this is the third one, Hoffman's elimination. It is a spontaneous molecular rearrangement of the drug in the blood itself without agency of enzyme. Blood is not taking the help of the enzyme. The blood is not taking the help of the enzyme. Without enzyme, I will do so. I do not want your help. Thank you so much, but I do not require. Thanks a lot. Okay, like that. Okay, can we go ahead? So this is the thing. Read the question. We will solve some questions and move ahead. Read the question and tell me the answer. Can you read the question and tell me the answer? Can you please read it? All are enzyme inhibitors except. I'm asking except. Which of the following is not enzyme inhibitor? Am I live? Please give me the answer. Huh? So use the mnemonic. What is the mnemonic? Vitamin K cannot cause enzyme inhibition. This is a list of inhibitors. The other list, Hana, this is the list of inhibition. You see in this list what is not coming. What is the other list? What is the other list? The other list is GPRS cell phone battery dead. Now you tell me what is not coming. Huh? Apply. So can you see here? This is ketoconazole. It is coming here. This is valproate. It is also coming here. Now the main difficulty will be in C. Cimetidine is coming here, but the other C is not carbamazepine. This C is cimetidine. The other C is not carbamazepine. You can see here. The other C is ciproflox. The other C is cimetidine and ciproflox. Carbamazepine is coming here. So this C is the one here. It is shown here. So this, the one in the option, it is this C. So carbamazepine is the inducer. It's not inhibitor. Here the other C is ciproflox, that I want to tell. So you will get confused in the C. So learn all three. Here it is cimetidine and ciproflox, and here carbamazepine. So carbamazepine is a inducer, not inhibitor. Okay, so the correct answer is A, and you all are right. Why everyone is not responding? Please everyone respond. Okay, the next question in front of you. Which of the following drug is an enzyme inducer? Again apply the mnemonic, the same mnemonic. Vitamin, inducer they are asking. GPRS cell phone battery dead. GPRS cell phone battery dead. This is the mnemonic. Now use it, apply it. Rifampicin, is it coming or not coming? It is rifampicin. Isoniazid, is it coming or not coming? Ketoconazole and erythromycin, these all are inhibitors. Only rifampicin is coming here in this mnemonic. So rifampicin is the answer. So you have to use these mnemonics again and again. There are many questions based on that. One more question I would like to ask. What is Hoffman's elimination? I told you, na. Can you read out and tell me what is the correct answer? What is Hoffman's elimination? Is it inactivation of the drug by metabolizing enzyme? Is the drug taking the help of the enzyme? Or it is unchanged excreted by the kidney? Or is it excreted in the feces? Or is it inactivated by itself by molecular rearrangement without the agency of enzyme? So what is correct for Hoffman's elimination? I guess yes, you all are right. Absolutely right. Gohil, absolutely right. Neha, everyone is right. So correct answer is D. Very good. I'm very happy. The correct answer is D. Tell me the name of the drug. Write down in the chat box. What is the name of that drug? It is also frequently asked question. The drug showing Hoffman's elimination. The drug showing spontaneous rearrangement to get convert from non-polar to polar for metabolism. So the name of the drug is absolutely right. It's atracurium. So please learn the name of the drug also. You get questions on that. Yes, absolutely right. So we are done with absorption. We have seen the effect of pH on that. We are done with distribution. We are done with metabolism. Now it's time to understand the excretion and pharmacokinetics and move on the next chapter, pharmacodynamics. Okay, we have to do 5 chapters today. Come on, people, we will be a little bit fast. This is the first chapter going on. Okay, 4 aur hain karne ke liye. So what is excretion? Excretion is finally passage of the drug in the urine. Passage of the drug in the urine. Excreted out of the body. That is excretion. To understand the excretion, you have to understand two terms. What are the two terms? Rate of elimination and clearance. If you understand the two terms, it will be easy for you to understand the mechanism of excretion of the drug from the kidney. Okay, what are the two terms? Rate of elimination. I will say it R. Rate of elimination. Can you see this is kidney? This is the yellow organ you can see. This is kidney. This is the blood entering in the kidney. This is afferent arteriole. And this is blood coming out of the kidney. This is efferent arteriole. And inside which? Inside the afferent arteriole, this is the drug. When it goes in the kidney, a portion of the drug is excreted in the urine. The remaining portion will come back in the efferent. Now the remaining portion will go in the afferent again in the next cycle. Again in the next cycle, a little bit is excreted. The remaining will go here. Again in the next cycle, a little bit excreted and the remaining will go. So one time will come, the drug is completely excreted out. Okay. So this is known as rate of elimination. Rate of elimination is how much is excreted per unit time. How much drug is excreted in urine? Tell me in grams, in milligrams. Tell me in milligrams. How much drugs is excreted? Upon per unit time. It can be per minute. It can be per second, it can be per hour. Per minute, per second, per hour, how much drug is excreted out. So here you can see it is 500 microgram per minute. 500. So it is gram per time. It is gram or milligram. You can tell me in milligram or gram. How much drug is excreted? It is gram or milligram, the weight of the drug upon time. Per time. It is per second, per minute or per hour. That is known as R, rate of elimination. It can be fast, it can be slow. In some drugs, it's very fast. excreted. So very fast it will become 0 in the blood. But in some drugs, it's slowly, a little bit every time in every circle, a little bit excreted. So multiple circles are required. So it takes long to get excreted out. Samajh mein aaya? How many of you got it? What is rate of elimination? The next thing I want to tell you here is the clearance. What is clearance? Can I tell you what is clearance? Huh? Clearance kya hai? I told you this is afferent arteriole. Okay, and this is efferent arteriole, and this is the organ of excretion, that is kidney. Okay, from which the drug is excreted in the form of the urine. In the urine, the drug is excreted out. So when the afferent arteriole, the plasma is going inside the kidney, a little bit of drug is excreted. It is not all the drug. For example, it contains 10 microgram per ml. This is the plasma concentration of the drug. This is known as PC. PC is plasma concentration. How much drug is present in afferent arteriole? It can be any. Just suppose here what it is the value. It is 10 microgram per ml. It is the value. It is a plasma concentration. A little bit is excreted and the remaining will go back in the efferent arteriole. See in the efferent arteriole, what is the concentration? It is less than 10 microgram. Why it is less than? Why it is less than, not 10? Less than 10, because remember, a little bit is excreted, so it means a little bit of plasma is cleared of the drug, we have 5 liter of plasma. The drug is uniformly distributed in 5 liter of the plasma, if I have taken any drug, it is going in my blood, we all adult humans have 5 liter of plasma, 5 liter of blood. So drug is uniformly distributed. Now I want to excrete the drug. So every time my blood is going in the kidney, every time kidney is excreting a fraction of drug in the urine. So a little bit of plasma get cleared of the drug every time. So a little bit. One time will come in multiple cycles, that complete 5 liter is getting cleared. Say yes. So this is known as clearance. How much ml of plasma? How much ml of plasma? What is the volume of plasma which get completely cleared of the drug in 1 minute? In 1 minute. That is known as clearance. Kitno ko samajh mein aaya? It's difficult. The rate of elimination was easy still, but clearance is difficult. So what is clearance? How many of you tell me? How many of you understood, Can you tell me what is clearance? You got it? So clearance is the volume of the plasma that get 100% cleared of the drug per unit time. That is the definition of clearance. So the formula of the clearance is in front of you. Clearance is equal to drug elimination rate, that is R upon plasma concentration. So here you can see what is the rate of elimination of the drug in this. The rate of elimination every time 500 microgram is excreted per minute. That is rate of elimination, that is R, the value of R. Every minute this much is excreted. And what is the plasma concentration? PC. PC is 10 microgram, not micro, yes, 10 microgram per ml. So the formula of clearance is equal to R upon PC. R upon PC. So apply it. What is R? 500 microgram. And what is PC? 10 microgram. If you do so, the answer is 50 ml per minute. So every minute 50 ml of the plasma get cleared. 50. So if you want to clear 5000, every minute 50 is cleared. So you require every minute 50. So 50 into 100, that will be 5000. So in 100 cycles it will be done. Got it? This is the clearance. Got it? So clearance is the volume of the plasma which get cleared per minute, per unit time. If you got the definition, the meaning, it's good. If you didn't got it, you have to learn the formula. What is the formula? Formula of clearance is equal to rate of elimination upon plasma concentration, R upon PC. So please learn this formula. It will be helpful for you. R upon PC, the formula. Okay, got it? This is the formula. Can we go ahead? Now, I want to tell you the order of kinetics. The last thing in the pharmacokinetics. After that, we will move on pharmacodynamics. The last thing here I would like to tell you is the order of the kinetics. What is order of kinetics? What is order of kinetics? Listen, let me ask you a question. See this image. Can you see this image? There are all the drugs follow one of the two order of kinetics, either zero order, either first order. Some drugs follow zero order, some drugs follow first order. What do you mean by that? Practically, how it is important for us being a doctor to understand this. Let me explain. See, can you see this is kidney? Yes. Can you see this is afferent arteriole? The blood is entering in the kidney. See the arrow. And this is efferent arteriole. The blood is coming out of the kidney. See the arrow. Got it? Now see the plasma concentration of the drug shown here. For example, the plasma concentration is 10 milligram per ml. In 1 ml of plasma, 10 milligram of drug is present. And this is the urine. The drug is excreted in the urine. How much drug is excreted? Every minute 1 milligram. Every minute 1 milligram is excreted. Every minute. So this is R. So this is PC. This is R. Got it? So every minute 1 milligram is excreted. Now let me ask you a question. The plasma concentration is 10. Please hear my question carefully. When the plasma concentration is 10, the rate of elimination is 1. Every minute 1 milligram is excreted when 10 milligram is present. What if instead of 10, if the plasma concentration is 100? What if instead of 100, if the plasma concentration is 1000 or 10,000? So I'm increasing the plasma concentration. What is rate of elimination in that case? Can you tell me? What is rate of elimination in that case? Give me a minute. Huh? Can you tell me? What is the rate of elimination in that case? Something have happened. I'm sorry. Did you understood my question? Huh? So in the plasma concentration, so it will increase. Someone is saying that it will increase. So it will not always increase. Your answer should be Neha. Ma'am, what is the order of kinetics? Is it zero order or is it first order? When in the plasma, it is not always directly proportional. When in the plasma, 10 milligram, just suppose I am taking a tablet, it get absorbed. And in my blood, it is 10 milligram per ml in my blood. It can be anything. So every time in my urine, 1 milligram is excreted, 1 milligram per. So if my blood contain 10 milligram, 1 milligram is excreted in urine. But instead of that, why the scene is changing again? Just a second. So instead of 10, if my blood contain 100 or 1000, what is the rate of excretion in that case? So it depends on the order of kinetics. Is it zero order or is it first order? If it is zero order, whatever is the rate, whatever is the rate, whatever is the plasma concentration, the rate remains constant. It is 1, 1, 1. So I call this kidney as ideal kidney. In zero order kinetics, the kidney is very, fixed. It is disciplined. It will always excrete with the same rate. प्लाज्मा में 10 है, 100 है, 1000 है, 10,000, उसको कोई मतलब नहीं है. मैं तो एक ही एक्सक्रीट करूंगी 1 मिनट में. तुमको जितना रखना है प्लाज्मा में रखो, मैं 1 मिनट में एक ही एक्सक्रीट करूंगी. So that is the kidney in zero order kinetics. So in zero order kinetics, it is always same. The rate of elimination is constant, whatever is the plasma concentration. So this zero order is very, just suppose you are asking the patient to take one tablet, for a disease, you are giving a prescription to the patient, take one tablet daily. So patient is taking the 10, the plasma concentration of the patient because of one tablet is 10, patient is not getting the relief or whatever, so without consulting you, patient is increasing the dose by itself. So instead of 10, the patient is making it 100, but the kidney is still excreting 1. So the patient can have toxicity in that case. So zero order kinetics are the drugs which are dangerous. So whenever you are prescribing a zero order drug to any patient, you have to warn the patient that without consulting me, please don't change the dose. Please don't increase the dose. You can have toxicity. It can be sometime very severe. Got my point? So death can also occur. So this is zero order kinetics. How many of you got it? How many of you got it? ये समझ में आया? In first order, it's directly proportional, as Neha was saying. Someone was saying, no? So it is directly proportional in first order. In first order, if you increase the plasma concentration, by 10, instead of 10, it's 100. By 10 times you are increasing. This will also increase 10 times. Instead of 1, it will become 10. If you are increasing it 100 times, it will become 1000. This will also increase 100 times. So it will become 100. So when the plasma concentration is 10, the excretion is 1. When the plasma concentration become 100, it become 10. When it become 1000, it become 100. So every time 1/10 is excreted. Every time. This time also, this time also, this time also. So rate of elimination is directly proportional to plasma concentration in case of first order kinetics. But in zero order kinetics, the rate of elimination do not depend on plasma concentration. Plasma concentration 10, 100, 1000 doesn't matter. Rate of elimination is 1, 1, 1. That is constant. I mean to say it's constant. So this is the meaning of order of elimination. So being a doctor, you should know the drugs which follow zero order kinetics because they are dangerous. They can cause a toxicity. And now you have to ask the patient, don't increase the dose by yourself. Sometimes patients do. Without consulting the doctor, they just increase the dose by themselves. So you have to consult them. You have to warn them. Don't do this. With this, it's okay. But with this, it's not allowed. It can be dangerous. How many of you got it? How many of you got it? Do you have any confusion? Can we go ahead? Yes, I will finish the complete pharmacology in 2 portions. This is part 1. Okay. So in zero order kinetics, the rate of elimination is constant. Now there is a formula. The rate of elimination is directly proportional to plasma concentration to the power order. This is the formula. You have to learn this formula. This is a formula in chemistry. You have read this formula in chemistry also in 9th standard, if you remember. Now apply 0 here and apply 1 here. 1 by 1 we will do. First apply 0. So rate of elimination is directly proportional to plasma concentration की power में 0. And here rate of elimination is directly proportional to plasma concentration की power में 1. Anything to the power 0 is 1. So rate of elimination is constant. It doesn't depend on plasma concentration in zero order. In zero order. But in first order, the rate of elimination is directly proportional to plasma concentration. So here, if you are increasing the concentration, it's still 1, 1, 1, 1, 1. But here, if you are increasing the concentration, it will be directly increasing. So every time in first order, you have seen the 1/10 of the drug is excreted. So here, fixed fraction is excreted. Got it? So in zero order, the fixed amount is excreted every time 1, 1, 1, 1, 1. But here, the fixed fraction is excreted every time 1/10, 1/10, 1/10. How many of you got it? So here we have two order of kinetics, zero order, first order. Here plasma concentration to the power 0 is 1. Rate of elimination is constant. And here rate of elimination is directly proportional to plasma concentration. Here fixed amount is excreted. Here fixed fraction is excreted. Anyone have any confusion? Can I repeat or you got it? Can I repeat? Shall I repeat it once? एक बार repeat करूं? एक बार करती हूं. See, zero order, see one, first order. Everyone on the screen. See the zero order, see the first order. Everyone on the screen. Okay. So here we are having the plasma concentration is 10 milligram per ml. So rate of elimination is 1 milligram per minute. 10 pe 1. Every time it's 1 in one cycle. What will happen instead of 10 if we have 100 here and 1000 here? And what will happen instead of 10 we have 100 here and 1000 here? So if it is zero order, whatever is the plasma concentration, rate of elimination is always 1, 1, 1. It's always constant. So my point is rate of elimination is constant here in zero order. But here it's directly proportional. You are increasing it 10 times, 100 times. It will also increase 10 times and 100 times. So when it is 10, it is 1. When it is 100, it becomes 10. And when it is 1000, it becomes 100. So it is directly proportional, I mean to say. So here say, ma'am, every time 1/10, 1/10 or 1/10 is excreted. So you can say here constant fraction is there. So here constant amount is excreted. Constant amount is excreted 1, 1, 1, 1, 1. Here constant fraction is excreted every time 1/10, 1/10, 1/10. Here rate of elimination is constant. And here rate of elimination is directly proportional to plasma concentration. Last thing. Tell me the formula of clearance. What is the formula of clearance? Say ma'am, R upon PC. I told you. Here also formula of clearance, R upon PC. है ना? So here R is constant. I told you na, R is constant. So if R is constant, the clearance is inversely proportional to plasma concentration. Here R is directly proportional to PC. So both will rise, both will fall, they will cancel each out and clearance is constant. So in zero order, clearance is inversely proportional to plasma concentration. In first order, clearance is constant. देखो समझ में आया? बहुत अच्छी बात है. Very good, very good. लेकिन नहीं समझ में आया? कोई बात नहीं. Don't take the stress. Learn the summary. Nobody is going to ask you the concept in your exam. The people are going to ask the questions. The questions should be correct. Whether it is concept with the help of concept or whether you have learned it. So the summary is in front of you. Zero order, first order. The drugs follow one of the order, either zero order or first order. So zero order में rate of elimination क्या है? First order में rate of elimination क्या है? So in zero order, rate of elimination is constant. But here in first order, the rate of elimination is not constant. It's directly proportional to plasma concentration. Learn that. Here kidney is ideal. Here it is fluctuating. Got it? That is the meaning. Here a constant amount of drug is excreted every cycle. 1, 1, 1, 1, 1 in my example. Here a constant fraction is excreted every time. 1/10 in my example that you have to learn. The third thing and the last thing you have to learn. What about the clearance here? And what about the clearance here? So clearance is equal to R upon PC. Here R to constant hai. So clearance is inversely proportional to PC. है ना? And here clearance is equal to R upon PC na? They will cancel each out because they are directly proportional. So either both will increase, both will fall. So I mean to say clearance remains constant. Here the clearance remains constant. So question will come on these three. समझ में आया? अच्छी बात है. नहीं आया? Learn these 3 points. अच्छा, tell me which drug is dangerous. You tell me which drug is dangerous. Zero order or first order? Zero order में kidney is ideal ना. So in zero order, whenever the patient by mistake the patient is increasing the dose, है ना, without consulting a doctor, you have asked the patient to take a 10 milligram tablet. Patient is taking 100 or 1000 by mistake or accidentally patient is taking. So kidney will excrete 1, 1, 1. When the patient is taking 10, 1 is excreted, so 9 is remaining. But when patient is taking 10, 100 or 1000, still kidney is 1, 1. So here 99 or 999 will be pending. So it will cause a toxicity. Here 1/10 is excreted, so not very toxic. Here it is toxic. So these drugs are dangerous. So you should know the list of the zero order, not one order. So zero order drugs are in front of you. What is a mnemonic? I'm having a mnemonic. The mnemonic is watt power. What is the mnemonic? The mnemonic is watt power. 0 watt power. Have you seen? What is the unit of power? Watt. In physics, we have read that. So W for warfarin, A for 2A, alcohol and aspirin, and T for 2T, theophylline and tolbutamide, and T, power, is phenytoin. Okay, so 0 watt power. Say the full form. Say the full form. Warfarin, it's an anticoagulant. Aspirin, okay, antiplatelet drug. Aspirin के बाद warfarin, aspirin, alcohol, okay, theophylline, tolbutamide, and phenytoin. So please learn, these are dangerous drug because toxicity can happen on increasing the dose. Got it? Can we go ahead? So please learn this list. So we are done. Read the question and tell me the answer quickly. So what is true about zero order? Read the 4 options. Is the rate of elimination is independent of plasma concentration? Independent means constant. Is it so? Or rate of elimination is dependent on plasma concentration? Is it so? One of them will be true, है ना? Or clearance is constant, or half-life is constant. What is true? Who will tell me the correct answer? Absolutely right. The correct answer is A. It is the rate of elimination is constant in zero order. I hope you got it, है ना? So you people, I mean, most of the students always think कि मैम मुझे इन सबसे क्या करना? I am a doctor. I will practice. मुझे क्या करना? Which drug is following zero order? Which is following first order? How does it matter? It is mattering for you because whenever you are prescribing any drug following zero order, don't forget to warn your patient that don't increase the dose by yourself. Consult me before doing so. If you do it at your end by mistake or anything, it can lead to toxicity. It can lead to severe side effects, toxicity, and death also because the drug is following zero order. Got it? So you have to learn. So we are done with the first unit, pharmacokinetics. Can I start the second unit? Today I will teach you these 5. Today, part 1 pharma, part 2 pharma, in which I will cover the remaining all systems. It is scheduled on 13th of January on the same YouTube channel where you are watching right now. The timings are same, 6 to 11 p.m. in the evening on 13th. Today also the timings will be same. We have started at 6, maybe till 10 or 11 we will continue. So we have to continue with all these systems. Okay, today. So complete pharmacology in one shot. One shot means 2 parts. Okay, so let's start it. Let's come to the second unit, pharmacodynamics. Can I start? Pharmacodynamics. What is pharmacodynamics? Pharmacokinetics kya tha? Effect of body on the drug. Now I'm telling you effect of drug on the body. So here the patient is taking the drug via oral route. Drug is going inside, getting absorbed, reaching the blood. Now drug is going to site of action and shows mechanism of action. After that it gets metabolized and excreted. So pharmacokinetics is done, but I am not interested in that. Currently I am interested in mechanism of action of the drug. That is pharmacodynamics. So let's start pharmacodynamics. That is effect of drug on the body. So what the drug is doing on the body? I'm having headache, I'm having migraine, I'm taking a drug for that. I want the drug to go inside, it get absorbed from the blood, it should go to my brain in the cranial blood vessels and bind with the receptor and treat me. If I'm having diarrhea or constipation, I want the drug to get absorbed, go in the blood, from the blood go in the intestine, bind with the receptor and show your action. If the diarrhea is there, peristalsis is decreased. If the constipation is there, peristalsis is increased. Likewise, if I'm having a heart failure, I will take a drug to treat it. If I'm having bradycardia, tachycardia, I will take a drug to treat it. Drug will go inside, get absorbed from blood. It will go to its receptor present on the heart. It will increase the heart rate, decrease the heart rate. Likewise, so different drugs are given in different treatment. We know that. My point here is that all the drugs act via receptor. The drugs are acting via receptor. The target organ is having receptor. So this is a drug present in the blood. Okay, blood. Now the blood go everywhere. So the drug, for example, I'm having headache. I'm taking a drug for that, migraine. So drug is present in my blood. Now from here, the drug is going everywhere. But drug will act only on the cranial blood vessels, not anywhere else. Why? Because the receptor for that drug present here. If I'm having diarrhea, the drug will act only on the intestine, not anywhere else. So the drug is having a particular receptor on that particular organ. So let's talk about receptor. So pharmacodynamics is all about receptors. Can I start? Can I start? Yes. So if you want pharmacodynamics to understand, you have to understand the receptor. So let's understand the receptor because drugs act via receptor on their target organ. Different drugs have different target organ. Okay? Each receptor have 2 properties, affinity and intrinsic activity. Now you have to understand. Can you see this diagram? Can you see in this diagram? Understand the basic diagram. This is cell membrane. Now this is a cell. Okay, this is a cell of my target organ. This is a cell. Now this cell can be brain, it can be intestine, it can be heart, it can be kidney, it can be liver. भाई मुझे जो बीमारी है वो वाला organ का cell है ना? And this is the drug. The drug is present in the blood. From the blood, the drug will go to the target organ and bind with the receptor present on the cell membrane of the target cell. So can you see this is the cell membrane? This is the blue color cell membrane of the target cell. This is the cell membrane of the target cell. Respond. Got it? On the cell membrane, you can see the receptor. This is the cell membrane. You can see. This is the cell membrane. On the cell membrane, there is a receptor. Now drug will come and bind with the receptor. Okay? Based on the first understand what is affinity and intrinsic activity. So this is the drug. Drug. The drug is coming and binding with the receptor. The binding The binding is known as affinity. Affinity is just binding. Ability of the drug to combine with the receptor. Combine matlab bind. है ना? Coming and binding. Binding मतलब affinity of the drug. So if the drug want to act, पहली चीज है भाई bind हो. Bind ही नहीं होगी तो affinity क्या है? मतलब mechanism of action कैसे दिखाएगी? If the drug want to show a mechanism of action on particular organ, the drug should come and bind with the receptor of that organ. If the drug is not binding, but drug cannot act. Drug cannot act. दूर से थोड़ी जादू करेगी कि ठीक हो जाए. Drug will come and bind, है ना? So binding is affinity. After binding, just suppose binding is done. Binding is done. Now it will activate the receptor. It will activate the receptor. Activation is known as intrinsic activity. है ना? So first the drug will come and it will bind. So binding, the binding is affinity. And after binding it will activate. The activation is intrinsic activity. So say the two definition. What is affinity and what is intrinsic activity? So the drug is coming. The drug is coming. First the drug will bind with the receptor, affinity, and after that it will activate the receptor, that is intrinsic activity. So first understand the basics, the terms. How many of you got it, people? Bolo, samajh mein aaya? Based on the intrinsic activity, drugs are of 4 types: agonist, partial agonist, antagonist, reverse agonist. Let me explain you. Based on intrinsic activity, है ना? So let's come. Based on the intrinsic activity, drugs are of 4 types. What is the agonist? What is the partial agonist? What is antagonist? And what is inverse agonist? Reverse or inverse agonist? Okay, got it. Yeah, I will provide the annotated version every time I do so. This time also I will do Adhira. Definitely I will do. Hai? So concentrate now here. Definitely I will share the PDF on the Telegram group of this channel. Okay, so you can find it there. Come here now. So what is agonist? Defined. Intrinsic activity. So what is the difference in intrinsic activity in all of them? Listen. So again on the master diagram, where is my master diagram? I call this diagram as master diagram. Hai? The complete general pharmacology I show in this diagram only. You can see this is my target organ. This is my target organ. The drug is present in the blood. This is my drug. I want the drug to go on the target organ and bind with the receptor present on the target organ. This is the receptor. You can see I'm drawing the receptor. So I want the drug to go here and bind with the receptor first and then activate the receptor. That's what I want. I'm expecting the drug to do so. But this receptor is not a natural receptor for the drug. मेरे drug के लिए थोड़ी ना भगवान ने दिया. So this receptor is given for some physiological agonist. For example, if this receptor is for acetylcholine receptor, normally acetylcholine come and bind here. This receptor is alpha receptor or beta receptor, so adrenaline come and bind here. This receptor is, muscarinic receptor, nicotinic receptor, so acetylcholine bind here normally. So different receptors are there for different physiological agonists. But now the drug is present. Okay, so and now based on intrinsic activity, 4 types of drugs are there. So what is agonist? Agonist will bind to the receptor and activate it maximally like the physiological signals do. Like the physiological signal जितना उसको stimulate करता है उतना ही ये भी होगा. Got my point? Partial agonist में again the drug will come and bind with the receptor, but it will activate it not completely. It will activate it submaximally. Here it was activation maximally. Here activation is submaximally. That's why this was complete agonist. This is partial agonist. How many of you got it? How many of you got it? Listen, see this diagram. Everything is in this diagram. Listen, everyone here. So this is the drug and coming and binding here. After binding, 4 possibilities are there. Now imagine this receptor is muscarinic receptor. Muscarinic receptor pe normally acetylcholine come and bind, but now the drug is coming. Now there are 4 options. The first option, the drug is coming, binding and activating it maximally like acetylcholine do so. So this drug is known as agonist. It is maximally activating it like the natural agonist do so. Physiological agonist, that is acetylcholine do so. The second is partial agonist. It's partial agonist. This drug is also coming. It is also binding. It is also activating the receptor, but not maximally. It's submaximally. So I will call it partial agonist. The third drug is antagonist. Now there is a confusion. The third drug is antagonist. What does antagonist do? Who will tell me? What does antagonist do? Antagonist will also come. It will bind. Bind to sab karengi because affinity to sab mein hai. They will come. They will bind, but they do nothing. They neither activate nor deactivate. They do nothing. Now don't confuse. Antagonist se hame lagta hai they do reverse. No, they don't do reverse. They just bind and block it. Because ma'am, what is the purpose now? You are saying antagonist is just coming and binding. Not doing anything. Neither activating the receptor. No. Neither deactivating it. No, don't do anything. It is blocking. Antagonists are blockers. So now the natural physiological stimulus cannot come and bind. Who's the physiological natural stimulus for this receptor? I'm saying it's muscarinic. So normally acetylcholine come and bind here, no? So acetylcholine will not come and bind now because it is blocked. It is a blocker, है ना? Blocker जैसे हमने block कर दिया. So now acetylcholine will not show its action. So it is just a blocker. So that is antagonist. And last one is reverse or है ना? Inverse or reverse agonist. Inverse or reverse agonist. So this drug will also come and bind with the same receptor, but it will do the opposite as that of the natural physiological stimulus. So whatever, now just suppose acetylcholine coming and binding here, and it is increasing the secretions. So this will come bind and decrease the secretion. Whatever is the function, it was doing meiosis, it will do meiosis. So whatever the normal physiological stimulus was doing, it will do opposite of that. How many of you got it? So tell me, huh? So can I say agonist have intrinsic activity +1, है ना? Partial agonist have intrinsic activity, not complete one, it is less than 1, less than +1, because it is partial. Antagonist have no intrinsic activity, it is just a blocker. It is coming and binding, not activating, not deactivating. Inverse antagonist have intrinsic activity of -1. So it is submaximally doing the reverse, what the natural physiological stimulus do so. So say the definition. How many of you got it? How many of you got it? So what is agonist? It bind and activate it maximally. What is partial agonist? It bind and activate it submaximally. What is antagonist? It also bind but do not do anything. Neither activate nor do the opposite. No, it don't do. It's just block, है ना? So that the natural physiological stimulus do not come and bind here, है ना? So it is decreasing the action of the agonist, but it itself have no activity. And inverse agonist bind to the receptor and produce the opposite effect. So please learn the intrinsic activity. You get many MCQs, simple MCQs, है ना? So, okay, I will give you a question. You just tell me the answer. Your options I am first writing. Intrinsic activity is equal to 0, intrinsic activity +1, intrinsic activity -1, or intrinsic activity less than 1. My question is, what is the intrinsic activity of agonist? What is your answer from ABCD? What is your answer of ABCD? From the ABCD, can you tell me the answer? Write down. Can you tell me the answer? Agonist का intrinsic activity क्या है? Yes, it's maximally stimulating the receptor. Correct answer is B. What is the intrinsic activity of partial agonist from the same 4 options? What is the partial agonist ka intrinsic activity? What is the correct answer? Yes, it is less than 1. Very correct. And what is antagonist? What is the intrinsic activity of antagonist? Antagonist का intrinsic activity क्या है? What is the intrinsic activity of antagonist? Is it 0 or -1? Anta देख के हमें -1 tempt करता है. No. It's just a blocker. It's just a blocker. So correct answer is A. I hope you people are right. And if I say what is the intrinsic activity of inverse or reverse agonist, in that case answer will be -1. Got it? So this is the summary. I hope you all got it. Give me a thumbs up if you got it. I'm summarizing. Someone is asking me to summarize. I'm summarizing. So this is the cell membrane. So this is a receptor, this is a receptor, this is a receptor, this is a receptor. This is a receptor present on the cell membrane. So this is the drug coming and binding. This is drug A, this is drug B, this is drug C, and this is drug D. 4 type of drugs are there based on intrinsic activity. Normally, Z is the natural physiological agent which comes and bind on this receptor. These receptors are for Z. Z is any natural physiological agent. Normally Z come and bind here. But now the drug is present, drug is binding. So A is a drug which is coming and binding here and stimulating the receptor in the same way like the Z do. Like the Z do, and maximally stimulating it. So intrinsic activity is maximum, that is +1. B is also stimulating the receptor, but not maximally. Like the Z only it is stimulating, but a little bit lower side. So less than 1. C is also binding. It is not activating. It is not at all activating this receptor. Neither activating nor deactivating. It is just blocking. It is just blocking here. It's a blocker. So that Z cannot come and bind here. So intrinsic activity is 0. Okay, and finally D is coming and binding with the receptor and doing the reverse as that of Z. Z यहाँ पे जो भी करता था उसका उल्टा. If Z was increasing the contractility, it is decreasing the contractility. If Z was doing the meiosis, it is doing the meiosis. Whatever Z was doing, it is doing the opposite. So here the intrinsic activity is equal to -1. How many of you got it? How many? I tried my best. So you can see here, intrinsic activity, this is 0. This is positive side, this is negative side. So you can say, ma'am, this is agonist. This one you can get the graph in your exam. You can say ये 0 से ऊपर है and +1 this is above 0 but not maximum +1. This is partial agonist. This one is partial agonist. 0, just 0 is antagonist. एंटागोनिस्ट है ना, एंड -1 is inverse agonist. I hope you got it. So you can get this graph also. Can we go ahead? Can we go ahead? Hana? So the next thing I would like to tell you is dose response curve, known as DRC. DRC. It's very important topic, a new topic. Dose response curve. Hana? You will understand, being a doctor, why it is important for you to understand the dose response curve before prescribing any medicine to your patient. Now you're a doctor. Now you will prescribe the medicines to your patient. Hana? Before prescribing any medicine to your patient, you should be justifiable. This is the best medicine for my patient from all the options available. For example, my patient is having malaria. There are many anti-malarial drugs. I'm having the option. I will prescribe the best one. So who will say this is the best drug, ma'am, not this one? I'm having multiple options. Huh? So whenever the medical representative come to the doctors, the new drugs are coming in the market, they will show that what better this drug is having as compared to other drugs which are already present in the market. So they will give you the dose response curve of that drug, and you have to understand that drug, and you have to decide which drug is better for your patient. Got it? Let me explain you. So it is a graph in which there is a x-axis and there is a y-axis. There is a x-axis and there is a y-axis. Listen, please understand it. Let me explain you. So what I'm taking on the x-axis, what I'm taking on the y-axis, that matters. Hana? On the x-axis, I'm taking the dose of the drug. Okay, dose, what dose I'm taking. And on the y-axis, I'm taking the response of the drug. Dose of the drug and response. Dose means I'm taking the plasma concentration of the drug. Finally the dose which is reaching in my plasma. ठीक है? For example, I am a hypertensive patient. है ना? मुझे BP है. BP है मतलब BP तो सबका होता है ना? The normal blood pressure is 120/80. My blood pressure is more than that. So for example, my blood pressure is 180 by, let's say, 100. Or say 200 by 100, malignant hypertension range. Okay, so I'm hypertensive. So I will take a drug. So for example, I'm taking a drug in low dose. So the response is less. If I increase the dose, the response will increase. If I'm taking at low dose, only 10 mm of BP is falling. So instead of 200, it becomes 190. So response is little bit. But I want up to 120. So I increase the dose little bit more. So 20 mm is falling. I increase the dose little bit more. So only 30 mm is falling. So 200 se 170 ho gaya. 30 mm is fall. But I want to take it to normal 120. So I will increase. 1 point will come. Even on increasing the dose, the response will not always increase. So this is the curve. This is the shape of the curve. Got my point? This is the response we measure. Depending what is the drug we are giving, the response depend on that. For example, I'm having severe headache right now. I will grade the pain as 10. मुझे severe pain है ना? So you will say, ma'am, grade it. Is it 1? 1 is the least and 10 is most worst pain you are having. So what kind of pain you are having right now? Can you grade it? I will say it's severe pain. It's 10. You will say, okay, let's give you a painkiller to you. Let's give an NSAID to you. You are giving a medicine too for my headache. है ना? So after taking the medicine, you are saying, ma'am, what is the response? So I will say it's 7 still there, but 3 of it fall. है ना? It is a relative thing. So you will say increase the dose. So 1 point will come. It will 100%. It will, subside. Got my point? So that is the response we are measuring. So what is the disease? Depending on that, we are seeing the response. But for all the disease, this curve is constant. So on increasing the dose, the response will increase. After a point, it becomes constant, even on increasing the dose. So first you are giving the 10 milligram of the tablet, 20, 30, 40, 50. Till 50, it was increasing. Now you are giving 60 milligrams, 70, 80, 90, 100, whatever. That response is same. How many of you got it? This shape is known as hyperbola. What it is known as? Hyperbola shape. Say yes, people. This shape is known as hyperbola. Say na, got it. Now doing the calculations and comparing various drugs on this hyperbola is difficult. So let me shape the curve. I want to make it a sigmoid curve. So instead of dose on the x-axis, I will take the logarithm of the dose. You know what is logarithm in mathematics? You have read the chapter as logarithm in your 9th standard, I guess. I was having it on 8th or 9th standard. So instead of dose, you take logarithm of the dose. So the same curve. Dose की जगह मैंने log of dose ले लिया. Logarithm. So instead of 10, I will take log 10, 20, log 20, log 30, log 40, log 50, log 60, whatever. So whatever values I was taking it here, 10, 20, 30, I will take the logarithm of them. And here still response, the same response. So यहाँ तो response का response ही है on the y-axis. But on x-axis, instead of dose, I took the log of the dose. So the shape will change. Shape will become like this, and it is known as sigmoid shape. So I changed the shape from the hyperbola to the sigmoid. Because on sigmoid, the calculations and comparing the various drugs is very easy. In hyperbola, it's difficult. कितनों को समझ आई? People, you don't respond. Come on, say. समझ आया क्या? So what I am doing? So I am making a DRC. What is the DRC? Dose response curve. DRC. Very easy to understand. So on the x-axis, it's dose. On y-axis, it's response. So we call it DRC, dose response curve. It's a graph between dose and response. So whenever we take dose and response, it's hyperbola, but we don't want it. In hyperbola, the calculations are difficult. So let's change it. Let's change it. So instead of dose, you take logarithm of the dose. It's better to take the logarithm of dose. And instead of response is response only. So this shape will convert into sigmoid shape. So basically, I'm teaching you log DRC. So अब मैं पढ़ा रही हूँ आपको log DRC. Can I start log DRC? So you can see, let's start the log DRC. है ना? You will say, why it is important for me to understand the log DRC of all the drugs? For 4 things. These are the 4 important parameters you come to know for your particular drug. है ना? I'm having 2 drugs for a disease. है ना? A and B. Both are anti-HIV drug. Both are anti-TB drug. Both are anti-malarial drug. है ना? Both the companies, both the brands, they are challenging my drug is best. My drug is best. है ना? So they are saying the doctor, you are a doctor. Please prescribe my drugs to the patient. This one is saying, no, please prescribe my drug to the patient. So you are the one who is going to decide. You have to do the justice for your patient. It is not whatever you will prescribe, your patient is going to purchase that, है ना, and take that drug. So you should be sure enough that your drug is the best among all the available options for that particular disease in the market. Got it? So which drug is having more potency? You have to decide that. Which drug is more efficacy? Which drug among A and B is having more efficacy? Hannah, you have to see the slope of that drug. I will tell you what does the slope mean. And you should come to know the therapeutic index and therapeutic range for that drug. So these are the 4 important parameters which you will conclude from understanding the DRC. Let's talk about them one by one. मैं चारों की बात करूंगी एक-एक करके. Can I start? Potency. What is potency? Potency का क्या मतलब होता है? What do you mean by potency? Just suppose the 2 drugs are in front of you. This is a DRC. See the 2 drugs. This is a drug A. This is a drug B. For example, both of them are anti-HIV drug. है ना? For the same disease, the same mechanism, everything is same. The brand is different. Or say both of them are for fever, antipyretic drug. है ना? There are 2 brands. है ना? Excretion and Calpol. But both contain paracetamol. भाई है तो दोनों में paracetamol. This is also 500 paracetamol. This is also 500 paracetamol. But this one is Excretion. This is Calpol. The brand is different. है ना? So I should compare the DRC of both. है ना? So which drug is better? Both are for antipyretic drug to reduce the fever. So this is the sigmoid shape DRC I can see here. This is the sigmoid shape DRC I can see here. We will compare and decide which one is better for our patient. है ना? Just and this is the response. I want कि at least after taking the tablet 50% response होना चाहिए. 50% तो आए. So that drug is good. So I will fix a response. Okay, I will fix a response. For that particular response, है ना, drug A has to be taken 30 milligram and drug B has to be taken for this response. Drug B has to be taken 50. You tell me drug A is acting, है ना, only 30 milligram पे 50% response and drug B का 50 milligram पे 50% response. You tell me which is more potent. Which is more potent, A and B? A and B में से more potent कौन है among A and B? I'm asking you. Let me explain again. If you want 50% response in your disease, whatever is your disease, you want 50% response, 50% at least cure, at least 50% cure. So drug A has to be taken 30 milligram tablet. But for drug B, for the same 50%, you have to take 50 milligram, 50. So we have to take low dose of the A now. So A is more potent than B. This is how we compare potency. The definition of the potency means for a particular response, how much milligram or gram of drug you want to take. For a particular response, fix the response. You can fix the response at 50%, 60%, 70%. What do you want? Okay, at least in my patient, this should be the response. If the patient is taking the drug, at least इतना फायदा तो मिले. इतना तो मिले, है ना, in the treatment. So you are fixing the response. So for that particular response, tell me the amount of drug which is required. Amount of drug. So potency. That is potency. Potency is always measured on x-axis, not on y-axis. On the x-axis we are looking, and now there is a rule. You can see the 2 drugs are in front of you, everyone on the screen. You can see the 2 drugs are in front of you. This is the curve of drug A, and this is the curve of drug B. This is left side, this is right. A is left, B is right. So the drug which is on the left is more potent. It is always a rule. The drug on the left is more potent, because the left one is requiring low dose and the right one is requiring more dose. So the one which is requiring low dose is more potent as compared to the one which is requiring high dose. So the drug which is on the left side is always more potent. Left is potent, learn a rule. So this is potency. How many of you got it? कितनों को समझ में आया? This is potency. So it is amount of drug needed to produce a particular response. It is always measured on x-axis. Left side, jitna left-sided drug, it is more potent. So tell me, there are 3 drugs for a disease. The same disease. Both of them, all 3 of them, they are anti-malarial drugs. Same mechanism. Drug A, drug B, drug C. 3 different companies, 3 different brands, which you will prescribe to your patient according to the potency. Potency देखिए कौन सी अच्छी है, which is best among them, which is having maximum potency. Tell me the sequence of potency. Which is having maximum potency, which is having minimum potency. The more is the left, the maximum is the potency. So potency का sequence A followed by B followed by C. So maximum potency is A followed by B followed by C. So this is left and this is right. जितना left उतना potent, जितना right उतना less potent. कितनों को समझ में आया? Boss, समझ में आया क्या? Got it? Can we go ahead? So this is potency. Now the next criteria is efficacy. What do you mean by efficacy? What is efficacy? Let's talk about the same two drugs. Now these are the same drugs I have shown you, A and B, which is more efficacious. Potency mein you told me ki A is more potent, ma'am, because it is on the left side. It requires less dose for the same response. है ना? Potency is measured on x-axis. I told you. What is efficacy? What is efficacy? Efficacy. Okay. है ना? I told you all the curve. है ना? Here the response will increase. It will become constant after that. Here also it will increase. It will become constant after that. After becoming constant, even on increasing the dose, you cannot increase the response. So this is a point, the maximum effect. है ना? So drug A का maximum effect only 70% ही है. मैक्सिमम इफेक्ट 70 है ना, बट ड्रग बी का मैक्सिमम इफेक्ट मे बी यहाँ पे 90 आ रहा है ना, द लेबलिंग इज इनकम्प्लीट. 0.7, दिस इज 0.8, दिस इज 0.9. सो आई एम हैविंग हेडेक, है ना, माय हेडेक इज 10 out of 10. I want to treat it completely. Now you are giving me two options, ma'am. I'm having two drugs for you. One will treat your headache 70%, one will treat your headache 90%. Which you want? Of course, are you fool? I want the 90% one. है ना, I want the 90% one, है ना, so that my 90% headache is treated. So it is the maximum response the drug can give you. Here the maximum response is 70% of the disease that is cured. Here the maximum response is up to 90%. So which is more efficacious? B. So you are giving me two options, ma'am. I'm having two drugs for you, A and B. A will treat your headache by 70%. B will reduce your headache by 90%. So your response is 70. Your response is 90. So which would you opt? I will say, doctor, of course I want the 90% one, the more efficacious. You will say, ma'am, लेकिन तुम्हें dose ज़्यादा लेना पड़ेगा. If you are opting B, na, so you have to take more dose. Instead of 30 gram, you have to take 60 gram. I will say, it's okay, ma'am. It's okay, doctor. Instead of 30 gram tablet, I will take 60 gram, but taking 30 gram and treating for 70%, it's not wise decision. Taking 60 gram and treating for 90% is a wise decision. Got my point? So here among A and B. So I mean to say efficacy is measured on y-axis. Efficacy is measured on y-axis. Potency is measured on x-axis. And efficacy is measured on y-axis. Here we see the height. Here we don't see the left right. Here we see the height. Here we see the height of the curve. See this curve, which is more taller. You see there are two curves. Curve A, curve B. B is taller. The one which is the taller is more efficacious. So potency and efficacy. This is a summary. I am summarizing both in front of you. देखो. So what is efficacy? You tell me what is efficacy? You see the definition. It is the maximum effect produced by the drug, and it is measured on the y-axis, not on x-axis. So more taller is the peak. Tall, जितना tall होगा, उतना more efficacious है. So here the rule is taller, and there the rule in potency was left. The more left, the more potent. Here the more tall, the more efficacious. How many of you got it? So here there are two drugs, A and B. Summarize. Which is more potent, which is more efficacious? Potent कौन है, efficacious कौन है? Potent में see left right. Which is on the left side? I guess you can see A is on the left side. So A is more potent than B. So according to potency, A is more potent than B. But efficacious बताओ, who is more efficacious? You can see B is taller than A. So efficacy wise, B is more efficacious than A. है ना? So now धर्म संकट, तुम अपने पेशेंट को कौन सा दोगे? Now imagine you are in this situation. Imagine, है ना, there are two drugs in front of you, drug A, drug B, both are for the same disease, है ना. The A drug is more potent than B, but B is more efficacious than A. Which you will give to your patient? I'm asking you, which is a deciding factor? Which is a deciding factor? You got the meaning of both of them. Which is the deciding factor? The deciding factor is the efficacy. I told you the example, na. Drug A has to be taken 30 gram, but maximum response is 70%. Drug B has to be taken 60 gram, but maximum response is nearly 90 or 100%. है ना. सो पेशेंट को कोई आपत्ति नहीं है, ज्यादा खा लेगा. पेशेंट बोलेगा इट्स ओके डॉक्टर, इंस्टेड ऑफ 30 ग्राम आई विल टेक 60 ग्राम. लेकिन ये उसे कि कम खा के कम ठीक करो तो वो नहीं होगा, है ना. सो एफिकेसी is the deciding factor. Here among three drugs, tell me the sequence of potency and tell me the sequence of efficacy. I'm asking. First tell me the sequence of potency, ABC में. Tell me the sequence, most potent, second most potent, third most potent, and tell me the sequence of efficacy. Most efficacious, second most efficacious, and third most efficacious. Learn the rule. It's very easy. For potency, learn the rule. More is the left, more is the potent. And for efficacy, Learn the rule. More is the tall, more is the efficacious. So what is the sequence for potency? The sequence is, you can see A is on the left side, followed by B, followed by C. So A followed by B, followed by C. A is more potent than B, then C. C is least potent. But efficacy, C is the tallest, followed by B and followed by A. So it is C followed by B followed by A. So you can see how many beautiful questions can come in your exam based on the image-based graph questions. How many of you got it? Enjoying learning? So you can get simple question. ABC, CBA. Which drug you will give to your patient? You will give A or C? You will give A or C? I'm asking you. Would you like to give A because it is most potent? कम लेनी पड़ेगी. 0.001 देने से ही काम हो जाएगा. ये चलेगा क्या? कौन से दोगे drug? Which drug you will give? Or you will give C? Yes, C, because it is the efficacy which is the deciding factor. So which is more important? Efficacy is the more important factor among potency. If I'm having an option, A is more potent and A is more efficacious. So that is the best thing. You say, ma'am, potent bhi A hai, efficacious bhi A hai. So of course I will give A to my patient. Of course I will give A to my patient. है ना? But there is an option that A is more potent and B is more efficacious. In that case, go with B. So this is the two things you have, two type of scenarios you have. So let's go ahead. The summary is in front of you. You all got it? The potency is measured on x-axis and it is related to left-right. The more the left, the more is the potent. And efficacy is measured on y-axis. And it is related to height. The more is the tall, more is the efficacious. I hope this is the best concept I told you. Are you people prepared for the questions? Shall I tell you the questions to solve? Say yes, give me a thumbs up if you are ready and you want more questions on the graph. Few 2-3 questions I'm having. Give me a thumbs up. You got it? Can we go ahead? Hanji, bolo, respond. Can we go ahead? Yes. So the first question is in front of you. I guess there is a little bit lag. So I can see your answers later on. Okay, so let's start it. Let's start it. The first question is in front of you. You can see the 3 drugs in front of you. So you see this is DRC. This is logarithm of the dose followed response. So log DRC is there. You can see the tree. Let me ask you the question. My question is in front of you. Compare A and C. Tell me the potency wise which is best and efficacy wise which is best among A and C. I'm asking you to compare A and C. I'm asking you to compare A and C. I'm asking you to compare A and C. First potency batao, which is more potent from A and C? Which is more potent? So A is on the left side. So A is more potent. C is on the right side. Okay. So A is more potent than C. What about efficacy? See, ma'am, both are equally tall. Both are equally tall. So A is equal to C. A is equal to C. Efficacy wise, A is equal to C. Potency wise, A is good. Very good. What about efficacy? That height is same, na? So both are producing same response. Whatever is the percentage, 70, 80, 90, but they are same. The height is same. So it is potency wise same. So which drug you will give to your patient? Potency wise, A is better, but efficacy wise, both are equal. So of course, I will prefer A. I will prefer A. So final summary, I will prefer A in my patient. In my patient, I will prefer A. Got it? So this is a summary, the first question. The same thing is written in front of you. My second question for you, compare A and B. Compare A and B now. Don't look at C. Don't look at C. Compare A and B. First, tell me potency wise, what is your answer? And tell me efficacy wise, what is your answer? And tell me the summary which you will give to your patient finally after seeing all these. You're a doctor now, you will decide. Potency wise, although A is little bit on the left and B is little bit, but the gap is very less, hardly. So I will say they are equal. Potency wise, although A thoda zyada hai, lekin they are considering it equal. The gap is hardly minimum. You can neglect. You can neglect. So A is equal to B, potency wise. But efficacy wise, who's tall? A is tall, much tall than the B. B is short, A is tall. So efficacy wise, A is better. So again, I will prefer A. Again, I will prefer A. Here it is ulta. Here efficacy was equal and potency was more. Here potency is equal, efficacy is more. Teesra dekho, dharam sankat, the third question. Compare BC. Question graph is same. Now see my questions. Compare A and C. Again, potency wise, first you tell me the comparison, and efficacy wise, then you tell me the comparison, and finally, what is your summary for your patient? Which you will prefer for your patient from B and C. So C B and C C. B is on the left side. So B greater than C according to potency. Because it is on the left side. But according to efficacy, C is taller. B is short. So C followed by B. So in this dharam sankat, I call it. So what you will give to your patient? If you see the potency, you will choose this. But if you see the efficacy, you choose this. So finally, what is the summary? Efficacy is the deciding factor. Jab bhi dharam sankat aaye, to efficacy. So here my answer is B. I will prefer B. I will prefer B in my patient. I'm sorry what I'm saying. I will prefer C in my patient because C is more efficacious. Yes, C. I will prefer C in my patient. Can we go ahead? So the same thing is written. You want more question or you got it? So let me skip. So you can get multiple drugs also. है ना? Like the 4 drugs are there. A, B, C, D. चलो एक कर लेते हैं. A, B, C, D. Compare A and B only. Don't compare others. A and B. Can you see the red and green? A and B. Compare it. हाँ, compare जब भी बोलूँ तो you have to tell me 2 things. Potency and efficacy. Potency wise which is better, efficacy wise which is better. So potency wise you can see A is better than B because it is on the left side. Efficacy wise they are equal. A is equal to B. है ना? So I will prefer A. So the same, you know, different we can compare. Anyways, let's come on the next topic. Okay, can we come on the next topic? All the topics are very easy. The only thing you have to understand in depth. Once you understood the topic in depth, it's very easy to understand all the 19 subjects in the medical. All 19 subjects are super easy. The only thing, understand it. Anyways, let's come on the next topic. Hana? So we are done with potency. We are done with efficacy. This graph tells us 2 more things. Potency, it tells us. So being a doctor, we should see the potency and compare the potency of various options available in front of us. And we should compare the efficacy of various options present in front of us and then decide the choice of drug we are preferring to our patient. We prescribe to our patient, उसके बाद decide करो. ऐसे नहीं कि जो MR ने बोल दिया कि हाँ ये कर लो डॉक्टर साहब तो आपने वो कर दिया. No. Being a doctor, it's your responsibility to check the potency and efficacy and compare whatever options available on your table and then decide the best drug for your patient for that particular disease among all the options available. For the same formula, the brands are different. Okay, got it? Okay. Potency affect the organ. What is the question, CT? I didn't get your question. What is the potency? Potency is measured on x-axis. I mean, it is the gram or milligram of the drug you are giving to the patient to produce a particular effect. You want a particular effect. You want 50% effect. You want 90% effect. उसके लिए कितना ग्राम देना पड़ेगा? That is potency. It affect organ से क्या मतलब है? Can you elaborate your question a little bit? It affect organ. Whatever drug you will give, it will go on some organ. It will act on its receptor. It will show its action. What exactly you want to ask? I'm not getting it. So can you please elaborate a little bit? Huh? Sethi Usman. Okay. Chalo, let's go ahead. Meanwhile, you're right. We will go ahead. So next question, next topic is slope. So this graph tells us about the slope also. You will say, ma'am, why slope is necessary? No, listen. There is a patient having hypertension or I am having hypertension. There are 2 antihypertensive drugs. Hai na? The first drug is hydrolazine. You have heard it? It's the antihypertensive drug. Huh? And the second drug is hydrochlorothiazide. It's also an antihypertensive drug. Both of them are antihypertensive drug. They reduce the blood pressure and make it normal. So you will say, ma'am, both we can give to our patient. We can give this also. We can give this also. So I'm having the patient and the patient is having hypertension. Hana, I can give any of them and it will reduce the BP, make it normal. No, before prescribing, have a look on the slope. Have a look on the slope. This is known as steep slope. Anna, this one is known as steep slope. Let me tell you the meaning. And this one is known as flat. This one is steep and this one is known as flat. Let me tell you the meaning. Let me tell you. Listen, here we are giving this dose. Anna, so response is this. See the red line. Anna, first I am telling you the steep one. What is the meaning of the steep? See this curve. Hana, see, everyone see, I'm explaining. So I'm giving the 10 milligram of the tablet. So response is this one. Maybe the response is 10%. Hana, if we measure in percentage. So I'm increasing the dose to 20. The response becomes 40%. Hana, if I'm increasing it further, it suddenly shoot up to 60-70%. So on little increase of the dose, response is tremendously affected. I'm increasing the dose by little bit. Hana, but response is tremendously affected. Say, ma'am, what do you mean by that? I mean, these are dangerous drugs now. You ask the patient to take 1 tablet. So that your BP will become normal. 10% reduction will be there and your BP is hardly 130, 140. So 10% reduction ho jayega, so you will become normal. है ना? So just take 10 milligram. Patient is not taking 10. Patient बोले डॉक्टर साहब तो कुछ भी बोलते हैं 20 ले लो, है ना? 30 ले लो. So patient is by mistake only or by accidentally patient is taking the wrong dose, है ना? Patient is increasing the dose a little bit. Patient बोले उससे क्या फर्क पड़ता है? एक आधा tablet ज़्यादा ले लिया कोई फर्क नहीं पड़ता. और by mistake by patient has taken 2 tablets in a day. 1 in the morning he forgot and 1 in the evening he taken again. So it can happen with anyone. So by mistake, he has taken more dose. But there is tremendous response. Response is disproportionate to that of dose. We are increasing the dose a little bit. But the response is tremendous. So patient will go in hypotension. Uska BP ko zyada hi fall ho jayega instead of become normal. And it can be emergency. Say yes if you got it. Say yes. So this is known as steep. They are dangerous drug. They are dangerous. So whenever you are prescribing any drug which is having steep slope, warn your patient that take care of the dose, whichever I'm prescribing, take in that dose only. If you are taking more dose, it can be, it can cause adverse effect in you. How many of you got it? Huh? But see the second one. Second one drug is good one. It is having flat slope. What do you mean by the flat? Let me highlight the curve. Let me highlight the curve. So this is the curve here. You can see this is the curve. So here what we are doing, we are increasing the, this is the dose, this is the response. We are increasing the dose, the response is little bit increase. We are increasing the dose, it's almost same. We are more increasing the dose, it's almost same. We are more. The response is almost same or little bit increase. है ना? So even on increasing the dose, the response is not much increasing. So these are safe. I call it these are the safe drug. Patient एक की जगह 2 ले ले 3 ले ले कुछ ज़्यादा फर्क नहीं पड़ता. Got my point? So these are the safe patient. This is having flat slope. So here a little increase in dose changes the response tremendously. Steep curve. But here little increase in dose will change the response little only. So how many of you got it? How many of you got it? Yes. So this is the slope. So you have to look about the slope also. So graph is giving me, graph is giving me the idea about the potency of the drug, the idea for the efficacy of the drug, and the idea for, from the slope, I come to know which drugs have steep slope, which drug have flat slope. And based on that, I can decide which is best for my patient. And the fourth one is therapeutic index or therapeutic range. These are two different things. Let me tell you what is therapeutic index and let me tell you what is therapeutic range. I will tell you both one by one. These are two different things. Let's talk about therapeutic index first. You have to understand it. है ना? Index अलग है और range अलग है. So let's talk about index first. Therapeutic index. Okay, let's talk about therapeutic index first. Therapeutic index also known as safety margin. It's also known as safety margin. See, what I am telling you, you can see in this curve there are two DRC. There are two DRC. These are not two different drugs. No. It is not A and B. दो drugs नहीं है. It is the same drug. You'll say, ma'am, same drug के दो DRC? Yes. One is of effect and one is of side effect. है ना? One is of effect, one is of side effect. If you take the overdose of any drug, all the drugs have side effect. For example, we are taking an anesthetic drug. What I'm expecting, I'm giving anesthesia to a patient. We are operating. We want the patient to get anesthetized for the next few minutes or hours. After that, the patient become conscious again. So we want sedation, है ना? Or else we are talking about any sedative, है ना? Patient को नींद नहीं आती. Patient is saying, doctor नींद नहीं आती रात को. So we will say, okay, we will give some sedative to you. We will give barbiturate or benzodiazepine. So you are giving sedative. But overdose can lead to death. That's why it is used for suicidal purpose. नींद की गोलियां खा लेते हैं लोग, है ना? So this is the DRC for effect. Effect is sedation. And this is the DRC for the adverse effect. The adverse effect is death. Got my point? Got my point? So the gap between the two is known as safety margin. The two curves should be wide apart. है ना? Wide apart. है ना? So we will take 50% of both of them. We will take the midpoint here. We will take the midpoint here. We will take effective dose 50 and lethal dose 50. Median effective dose, है ना? So what is the definition? What is the definition? Listen, let me tell you. So whatever is your 100% response, है ना? So 50% response के लिए कितना dose लेना पड़ेगा, है ना? Just suppose I'm having 10 out of 10 headache. So I want at least 50% तो ठीक हो जाए, है ना? तो 50% ठीक होने के लिए कितना dose लेना पड़ेगा? 10 milligram. 10 milligram, है ना? और what is this is ED50, effective dose 50, है ना? What is lethal dose 50? Lethal dose 50 अगर 50% animals में इस पे death हो गई तो, है ना? We do it on animals, not on humans. So 50% animals die at 40 milligram. So 10 milligram पे effect आ रहा है और 40 पे death हो रही है. So this is the range, है ना? I have to give 10. I have to give my patient 10. Of course, I do not want to kill my patient. But I am safe अगर मैंने 20 भी दे दिया तो. I am still थोड़ा सा risky है लेकिन 30 तक भी जा सकते हैं. लेकिन 40 never touch, never. If you give the 40, patient will die. Patient will die. So the gap should be more. Gap more, you are in safe zone. This is known as safety margin. This is known as safety margin. So the gap between the two DRC. Which two DRC? Effect ka DRC and adverse effect ka DRC. The gap between the two. The gap, जितना ज़्यादा gap, that is known as therapeutic index or safety margin. It is also known as safety margin. How many of you got it? Got it? Say yes if you got it. So that is the gap. So that is known as therapeutic index or safety margin. So please learn that. And the second thing, this is therapeutic index. And the ratio, it is denoted by the ratio LD50 upon ED50. This is the formula. Now the second thing is therapeutic range or therapeutic window. Therapeutic range or therapeutic window. Let me explain you. Again, we are taking the 2 DRC. We are taking the 2 DRC. This is effect and this is adverse effect. This is effect. This is what do you want in your patient? What do you want? I want such a dose, at least minimum effect to ho, thoda to effect ho. This is the dose at which minimum effect is coming in the patient. And in the adverse effect, दिस इज द डोज एट विच मैक्सिमम टॉलरेबल इफेक्ट है, इसके ऊपर डेथ हो जाएगी. सो दिस इज द मैक्सिमम एक्सेप्टेबल एडवर्स इफेक्ट, है ना. सो द गैप बिटवीन द टू इज नोन एज थेरेप्टिक विंडो. द गैप बिटवीन द टू is known as therapeutic window. The gap between the two is known as therapeutic window or therapeutic range. You got it? Shall I repeat? Or you got the difference between therapeutic index or therapeutic window? See, this is the same curve. This is dose, rather it is logarithm of the dose. And this is response. On y-axis, we are taking the response. So this is dose response curve. Okay, so I'm taking the two curves. This is effect and this is adverse effect. This is effect and this is adverse effect for the same drug. Drug is A, same drug hai na. So if I take the midpoint of the two, this is known as ED50 and this is known as LD50. So the ratio of LD50 upon ED50 is known as therapeutic index. Therapeutic index is 50-50 है ना. It is LD50 upon ED50. ठीक है. But for therapeutic window, we have to take the 2 points. The minimum effect and maximum acceptable adverse effect. The gap between the two. The gap between the two, I mean on the x-axis, that is known as therapeutic window. So here we are not taking 50-50. Here we are taking the minimum effect and maximum acceptable adverse effect. है ना, not 50-50. है ना, so we are taking minimum here, maximum here. So the gap between the two is known as therapeutic window at right. Okay, got it? Got it? Can we go ahead? So that is the thing. So that's the thing. I guess we are done with this unit. So can we go to the next unit? We are done with pharmacokinetics. We are done with pharmacodynamics. I'm starting the next unit, antimicrobial drugs. Okay, so let's start the next unit, antimicrobial drugs, ultra important unit, antimicrobial drugs. Let's start it. Antimicrobial drugs. What are the antimicrobial drugs? Antimicrobial drugs are the drugs that kills the microorganism. There are 4 types of microorganisms. We have bacteria, virus, fungus, and parasites. We want to kill them because they are present inside the body of our patient and I want to treat my patient. Imagine there is a patient. The patient is having infection by one of them and I want to cure my patient. I want to treat my patient. So I will give a drug to my patient that will kill the bacteria, virus, fungus, or parasite so that my patient can be treated. So these drugs are known as antimicrobial. How does they kill what is the mechanism? How does they kill the organism? So there are 4 mechanisms. Based on the mechanism of action, there are 4 types. Let me explain you the 4 types. Can you see? This is a bacteria. This is a bacteria. Hana? This is the cell wall of the bacteria. You can see the blue color cell wall. So this is a bacteria. This is the cell wall of the bacteria. This is the nucleus of the bacteria. Inside the nucleus, this is the double-stranded DNA of the bacteria. And this is the ribosome on which protein synthesis takes place. Now I want to kill it. I want to kill it. There are 4 ways I can kill it. Can I tell you the 4 ways? Can I tell you the 4 ways? Number 1, you can give a drug that inhibits the cell wall synthesis. Cell wall synthesis. You can give a drug that inhibits the cell wall synthesis. I will tell you this. I will start from here right now. Hana? That is beta-lactam antibiotics. I will tell you the beta-lactams. Hana? These are the drugs that inhibit cell wall synthesis. No cell wall, the bacteria will burst and die. That is the first thing. Hana? There are certain drugs which cause pores in the cell membrane. In the cell membrane, they cause the holes or the pores. There are certain drugs which cause holes or pores in the cell membrane so that the cytoplasm will leak out and the bacteria will die. Hana? The second mechanism. The third mechanism, there are certain drugs that act on the nucleus and inhibit nucleic acid synthesis. They inhibit nucleic acid synthesis and kill the bacteria. Hana? I will teach you these also. Sulfonamides, trimethoprim, and quinolones. I will teach you this also. And there are 4th category of the drug that inhibit the ribosome. No ribosome, no protein synthesis, and the cell will die, or at least do not die. Stop. It will not do the cell division. So protein synthesis inhibitors, the 4th category. So these are the 4 categories. Hana? So these are the 4 mechanisms of action by which we can kill a bacteria. What are the 4 mechanisms? There are certain drugs which inhibit cell wall synthesis. There are certain drugs which causes holes in the cell membrane. There are certain drugs which inhibit nucleic acid synthesis. And there are certain drugs which inhibit the protein. I will teach you all one by one. Can I start antimicrobial? Give me a thumbs up. Are you people there? Can we start? So let's start the first category, the drugs which inhibit cell wall synthesis. Let's start with the first category. So antimicrobial we are going to take one by one. So the first category is in front of you, the drugs which inhibit cell wall synthesis. I will tell you the drugs which inhibit cell wall synthesis first. Okay? So I will teach you here beta-lactam antibiotics, the most important. These are the drugs which inhibit cell wall synthesis. What is a beta-lactam antibiotic? This is a structure. Why they are known as beta-lactam? Because they have a beta-lactam ring in their diagram. Have you seen the benzene ring? The benzene ring is a 6-carbon ring. But beta-lactam ring is a 4-carbon ring. Not 4 carbon, 3 carbon and 1 nitrogen. Can you see this ring is said to be beta-lactam ring. So carbon, carbon, carbon and nitrogen. This ring is beta-lactam. So any antibiotic having this ring is known as beta-lactam antibiotic. There are 4 type of beta-lactam antibiotics. What are the 4 type of beta-lactam antibiotics? Penicillin, cephalosporin, carbapenem, and monobactam. These are the 4. So I will explain you these one by one. Okay. The mechanism of action of all 4 is one. They all inhibit cell wall synthesis. So first we have to see the mechanism of action. How they inhibit the cell wall synthesis. How? Tell me the exact mechanism. So for that you have to understand cell wall banta kaise hai. So this is the bacteria. This is the cell wall of the bacteria. The cell wall of the bacteria made up of 2 alternate units. That is alternate polysaccharide. Nam, Nag. This is Nam. This is Nag. है ना? Nam, Nag. Mg, Nam, Nag. So alternate Nam and Nag are there. Got my point? This is the first layer. है ना? For example, this is the second layer. Nam, Nag. Nam, Nag. Nam, Nag. Likewise, it is there. है ना? The complete Nam, Nag. Alternate Nam, Nag is there. This is the cell wall made up of Nam and Nag. My question to you, how does the first layer bind with the next layer? I want to ask the cross-linking. How does cross-linking take place? Cross-linking. For the cross-linking, we require an enzyme. The name of the enzyme is transpeptidase. Transpeptidase do the cross-linking. You got my point? So this is the first layer in the cell membrane. This is Nam, this is Nag. Nam, Nag. Nam, Nag likewise. And this is the second. In the same way, this is the third. This is the fourth, one by one. It's a thick cell wall. So the Nam of them, they bind with each other with the help of a enzyme. The name of the enzyme is transpeptidase, and this is known as cross-linking. So for cross-linking, we require transpeptidase. For cross-linking, you can see the same diagram. This is Nam, this is Nag. This is Nam, this is Nag. This is Nam, this is... You can see the Nam. M. Can you see? Let me highlight. The M of this is connected to this. The M of this is connected to this. The M of this is connected. So Nam ke beech mein the bridges are formed, and this is known as cross-linking. You can see the bridges are everywhere. These are the bridges, and this is known as cross-linking, for which an enzyme is required. The name of the enzyme is transpeptidase. Ab ho gayi na baat khatam. So beta-lactam antibiotics inhibit transpeptidase. No transpeptidase, no cross-linking. No cross-linking, the cell wall ka layers get separated from each other, it will disrupt. So this is how it inhibits cell wall synthesis. How many of you got it? So normally this is Nam, Nag, and for the cross-linking, we require an enzyme transpeptidase, which causes the cross-linking. What does beta-lactam do? You can see beta-lactam will inhibit the transpeptidase. No transpeptidase, no cross-linking. The Nam will not be connected with each other. Each layer will separate from them. Cross-linking is gone and they will disrupt. So this is how cell wall is separated. The cell wall is disintegrated. So you can see this is the cell wall. You can see this is beta-lactam. The beta-lactam is coming. So this is cross-linking, so cross-linking is gone. So this is separated, and it will disrupt. How many of you got it? So it inhibits the enzyme transpeptidase. Please learn that. So this is the mechanism of action of beta-lactam. Everyone got it? This is the mechanism of action of beta-lactam. Once the cell wall is gone, now the bacteria will try to divide, it will burst and die. So these are bactericidal. Let me tell you ahead. Resistance I'm not telling you here. So there are 4 type of antibiotic: penicillin, cephalosporin, carbapenem, monopenem. The mechanism of action of all 4 is same. So first coming on penicillin. Can I start the chapter penicillin? Penicillin is the first antibiotic to be discovered by Alexander Fleming. So this is a classification of penicillin. You want me to teach you the penicillin? It's very easy. So these are the penicillin. Now the first thing in the pharmacology, the systemic pharmacology, you have to learn all the classifications at one place. Please learn all classifications at one place. Okay. So please, there are important few classifications which you cannot miss. If you wish, we can provide you a PDF which contain only classification, the latest classification of all the units. So all the CVS drug, all the CNS drug. So only classifications at one place. So before going your exam, you should revise that, so that if any question coming in your exam, the particular drug, first thing you should be identify कि वो drug है क्या. Classification सबसे important है. ठीक है, चलो. Let's come on the penicillins. You can see the classification of the penicillins. There are 3 type of penicillins: natural penicillin, semi-synthetic penicillin, and beta-lactamase inhibitor. I will explain you all. Natural penicillin is only one. Benzyl penicillin, known as penicillin G. Benzyl, it's only one. But you say, ma'am, if natural is there, why we are making synthetic? Why we are making artificial? Natural is there, na? Why you are making artificial? There are 3 problems in the natural. है ना, natural is acid labile. We take it by mouth, we make a tablet of benzyl penicillin and we take the tablet. It will go inside. In the stomach we have acid. Acid will disintegrate it. It will be ineffective. So it is acid labile. So always we have to give via injection. Injectable. Injections are not comfortable to the patients. Nobody likes injection. It is painful now. Everybody likes the tablet form or capsule form, I mean oral route. But here oral route is not possible because it is acid labile. So the first problem is acid labile. So no worries now. We have make an artificial version which is acid resistant. It is the only thing different from the natural one. Hana, here we have only one penicillin. The name of that penicillin is phenoxymethyl penicillin. It is known as penicillin V. This was penicillin G. This is penicillin V. G is natural, but the problem is acid labile. V is artificial, synthetic, and it is different from the natural. It is acid stable. So here we can take it in tablet form. That is the first problem. The second problem with the natural penicillin is that, so there is an enzyme known as penicillinase. Let me explain you the enzyme. Listen, you have to understand this. Before coming on the classification, the various mechanism of the resistance. Can you see this cell? Everyone here, this cell is bacterial cell, not human cell. This cell is bacterial cell. This bacteria is present in my patient's body and I want to kill it. You say, ma'am, very easy. Now you give penicillin. You give penicillin, it will get killed. Penicillin will go inside, inhibit the cell wall synthesis. The bacteria will die. I will say, okay, I will give penicillin. So this is the penicillin I have given, beta-lactam. Any of the beta-lactam I have given. Penicillin or beta-lactam I have given. So it is having a penicillin ka beta-lactam ring. Beta-lactam, the square ring. It is going inside. Once it is going inside, the bacteria have already synthesized an enzyme to degrade it. उसके अंदर पहले से ही बंदोबस्त है. Bacteria are very smart. They have developed the enzyme to degrade the antibiotic. It is known as beta-lactamase enzyme or penicillinase enzyme. So what does this enzyme will do? Before my antibiotic degrade the cell wall and kill the bacteria. Before my antibiotic degrade the cell wall and kill the bacteria, the bacterial enzyme is degrading the beta-lactam ring and inactivating my antibiotic. So this is the way of resistance. Bacteria are very smart. They are super smart. So it is penicillinase. Inside most of the bacteria, penicillinase is present. So my antibiotic is ineffective. I am giving the antibiotic to kill the bacteria. But before my antibiotic go and inhibit the cell wall synthesis, inhibit the transpeptidase, the bacteria is degrading the beta-lactam ring with the help of enzyme. So these are penicillinase, the bacteria which contain the penicillinase. So bacteria are smart than us. But don't worry na, हम भी तो smart हैं. We are also smart ना. हमने बोला अच्छा. So ring पहचान के कर रहा है ना. The bacteria is identifying the beta-lactam ring. Here is the beta-lactam ring. Can you see? Beta-lactam. What if उसको घूंघट पे ना के भेज दो? Cover the ring. है ना? Cover the ring with the घूंघट. I call it घूंघट. है ना? So cover the ring. है ना? With multiple side chains. है ना? यहाँ पे side chains. Now give the beta-lactam. So the ring is covered. So the enzyme will unable to identify it. Now it will go, inhibit the cell wall and kill the bacteria. So we are smart than bacteria. See what a wise step we have taken. है ना? हम खुश हो गए. अच्छा यार, तू ज़्यादा तेज चल रहा है. रुक. है ना? We will cover the beta-lactam so that the enzyme cannot recognize it. So we have overcrossed the resistance. How many of you got it? How many of you got it? What we have done? So such penicillins which we have created, these are known as penicillinase resistant penicillin. The natural penicillin के लिए this is present. Penicillinase enzyme is present. So there is no use of giving penicillin G to any bacteria. All the bacteria have enzyme for that. So we will cover it with a side chain. घूंघट पहनाएंगे हम उसको. And then we will send. So such a penicillins are known as penicillinase resistant penicillin. Penicillinase resistant. So the first problem with the natural penicillin is it is acid labile. So we are making acid resistant version. So second problem with the natural penicillin is penicillinase labile. All the bacteria have penicillinase enzyme for that. So we are making the penicillinase version, penicillinase resistant version. So that is the second artificial. How many of you got it? How many of you got it? But listen, let me complete this story. What I taught you, first we are giving a penicillin. So the bacteria already have an enzyme for that. Bacteria is degrading the ring. So we have covered the penicillin with the side chain. घूंघट पहना दिया. Now the enzyme cannot recognize it. So we humans were very happy कि we are smart than bacteria. But bacteria are still smarter than us. हमसे भी ज़्यादा smart निकले. उन्होंने बोला अच्छा ये बात है मुझे धोखा दोगे है ना. तो what the bacteria have done now? See बैक्टीरिया ने क्या किया है ना. चलो कोई भी पेनिसिलिन दो, वेदर यू आर गिविंग विदाउट घूंघट वाला और विद घूंघट वाला. आई मीन वेदर यू आर गिविंग नेचुरल पेनिसिलिन or you are giving the penicillinase resistant artificial penicillin, whatever you are giving, ultimately both the penicillin will go to the cell wall. In the cell wall, they will inhibit the transpeptidase enzyme by binding with a receptor. this receptor. This is known as penicillin binding protein. This is a target protein, and it will bind with its receptor. I told you all the drugs have receptor, so it will bind with its receptor. So bacteria will alter this receptor so that penicillin cannot bind it. अब वो घूंघट वाला हो या बिना घूंघट, whether it is a natural penicillin or penicillinase resistant penicillin, whatever penicillin is there, it will not bind with its target cell, so cannot show its action, है ना? So this mechanism is known as altered PBB. So bacteria are smarter than us. Altered PBB का कोई तोड़ ही नहीं है. ये वाले penicillinase resistant भी उसको नहीं मार सकते. Got the story? Say yes if you got it. Say yes if you got it. These are the ways to show the resistance, है ना? To show the resistance to these are the resistance के तरीके हैं. So the first mechanism, the bacteria is forming beta lactamase enzyme or penicillinase enzyme, and the second mechanism, the bacteria is altering PBB, alteration of penicillin binding protein. Got it? Got it? So that is the thing. So the natural penicillin were having 3 problems. I told you 2 now. So let me continue with the third problem. Natural penicillin have 3 problems. The first problem with the natural penicillin, it is acid labile. So we make an acid resistant version. The second problem, it is penicillinase labile. We make a penicillinase resistant version. Hana, the acid resistant version is only one, that is phenoxymethyl penicillin known as penicillin B. Hana, the penicillinase resistant version, these are घूंघट वाले. This is a chain, multiple side chains are there around the beta lactamase ring. है ना? That's why they are penicillinase resistant. So here 5 penicillins come. The mnemonic is condom. CONDOM. O is only one. है ना? One time, not 2 type. So C is cloxacillin. O is oxacillin. N is neficillin. D is dicloxacillin. And O is not double. M actually is CONDM. M is methicillin. So these have the multiple side chains, है ना, to cover the ring. Got it? Now the third problem with the natural penicillin is that it is having a narrow spectrum. It kill only gram-positive bacteria, not gram-negative bacteria. But we want to widen the spectrum. So the third extended spectrum penicillins are available, in which we have extended. We do not want to only kill gram-positive. Sometimes we want gram-negative to kill also. Sometimes we want anaerobes also to get killed, depending हमारे patient को कौन सा infection है. So based on that, we want to extend the spectrum. So here 3 type of penicillins are there: aminopenicillin, carboxypenicillin, urido, है ना, in which we are adding some functional group in the natural penicillin so that its spectrum is expanded, है ना. In the amino there are 2 AA, ampicillin, amoxicillin, AA. In carboxy it is CT, carbicillin and ticarcillin, CT. And in urido it's MAP, MAP. M is meslocillin, A is azlocillin, and P is piperacillin. So that is the extended spectrum. You have to learn that. Can I go ahead? आगे बढ़े? This is what I will tell you later on. Let me explain the natural and the artificial. So let's start with the natural, one by one. So first, the thing is that first I will tell you the natural penicillin, the 3 limitations and everything about that. We will start the artificial, semi-synthetic. No. So first I will tell you the acid-resistant version. Then I will tell you the penicillinase-resistant version. And then I will tell you the extended spectrum version, one by one. Classification we have completed. So let me cover these 4 things. Then I will come on the 5th one, that is beta lactamase inhibitors in the end. Actually, they are not penicillins. Let me explain. Yes, of course, it is enough for your exams. So the natural penicillin is benzyl penicillin. You know the 3 limitation. The first limitation is acid labile. This penicillin going in the stomach, the acid will destroy it. It's acid labile. The second problem, it is penicillinase susceptible. Hana? All the bacteria have enzyme which will degrade it. Hana? And third, it's having narrow spectrum. It kill only gram-positive, not gram-negative. To rectify it, we have the artificial penicillin. पर उसमें मैं आती हूँ. What are the adverse effects and uses? What are the uses? What are the uses of this penicillin and what are the adverse effects of natural penicillin? Natural penicillin have 3 adverse effects. The first is local irritacy. If you are giving the injection, it is painful, number 1. Number 2, hypersensitivity. But the most important is Jarisch-Hexamer reaction. You have to learn that. Jarisch-Hexamer, just learn the name. Jarisch-Hexamer reaction. What are the uses? What are the uses? There are therapeutic uses and prophylactic uses. In the therapeutic uses, the mnemonic is last man DP. Okay, so penicillin, the natural penicillin is first treatment of choice in all these. The mnemonic is last man DP. Let me explain. L for leptospira, A for actinomyces, S for streptococcus, staphylococcus, T for trypanoma, tetanus, M for meningococcus, A for anthrax, actinomycetes, D for diphtheria, and P for pneumococcus. And for all these, the penicillin, the natural penicillin is the first drug of choice. So the mnemonic is last man DP. Please learn that. And prophylactic uses are 3. RAB, R-A-B. You can learn the mnemonic R-A-B. R is rheumatic fever. A is agranulocytosis and B is bacterial endocarditis. What do you mean by prophylaxis? Patient don't have the infection, but prophylactically we are giving the penicillin. For example, the patient is having agranulocytosis. I mean the neutrophil count is less. So there are chances patient को recurrent infection होगा. So prophylactically we give. In case of endocarditis, before any treatment, surgery, we will give. Before any intervention, we give. In rheumatic fever, prophylactically we give for many years after the first episode so that repeat episode do not occur. So that is a prophylactic use. Hana? So that is the natural penicillin I taught you. I taught you the natural penicillin. Now I'm coming on the artificial penicillin. That is semi-synthetic penicillin or artificial penicillin. So semi-synthetic or artificial penicillin may, I will tell you three categories. The first is penicillinase resistant penicillin. You have seen the classification condom. Semi-synthetic may. Hana? The first one is this one. Okay. Oh, I'm sorry. The first one we are taking the acid resistant. Acid resistant, that is phenoxymethyl penicillin, penicillin 5. It is acid stable. All things are exactly same as that of natural. Only thing it is acid stable, so tablets are available. It is known as penicillin 5. Penicillin 5, it is acid resistant. Hana? The next is penicillinase resistant. The mnemonic is condom. Hana? You can see the side chains. Can you see? Can you see the side chains? See this beta-lactam. Beta-lactam is throughout covered with multiple side chain. I call it ghungat. इसको छुपा के भेज दो, है ना? So I have covered it with the side chain so that this enzyme cannot recognize it. है ना? It is highly penicillinase resistant. Got it? Now coming on the extended spectrum, which is of 3 type. है ना? You will say what is the difference between these 3? Natural penicillin kill only gram positive. है ना? But amino 1, what does they kill? They kill gram positive like the natural. Along with that few gram negative. कौन से? H. influenza, E. coli, Proteus, Salmonella, Shigella, H. pylori. These are only few gram negative, not all. है ना? The amino 1. The next is the carboxy. Carboxy kill additionally Pseudomonas and Proteus also, which were not here. So additionally Pseudomonas and Proteus. Proteus यहाँ है but not very good killing power. Here better killing power. And the third is Urido. Urido are best for the Pseudomonas. 8 times more potent, and they have additional Klebsiella activity for the Klebsiella and Enterobacteriaceae other members also. Activity for bacterioids also. So largest spectrum is or Urido. Urido का सबसे बड़ा spectrum है. Got my point? So shall I tell you the last thing here? Beta-lactamase inhibitor. It's difficult to understand, people. Listen, what is beta-lactamase inhibitor? Listen. There are 3 beta-lactamase inhibitor. Clavulanic acid, sulbactam, tazobactam. What do you mean by that? See, this is a bacteria. Can you see this is a bacteria? What is the problem here? Resistance is the problem. I want to kill it with beta-lactam. So I'm giving the beta-lactam. The beta-lactam is going inside. So the bacteria have developed the resistance. The first thing bacteria have done, make an enzyme. The bacteria have synthesized an enzyme that will degrade the ring. उसका हमने solution ढूंढ लिया. We have the solution for that. We covered the beta-lactam ring. We have produced penicillinase resistant penicillin. So the second thing bacteria have done, bacteria have synthesized penicillin binding protein so that the natural penicillin cannot go and cannot bind there. Got my point? So that is. Now what is the solution of this? We have created beta-lactamase inhibitors. What we will do? Listen. Ye natural this is one of the beta-lactam. We do not give it. Before that we will give it beta-lactamase inhibitor. One of them. They also have beta-lactam ring in them. It's like a movie story, you can understand. This is the main hero, this is the side hero. But they are looking similar. दोनों हम शक्ल हैं. So first we will send the side hero. Beta-lactamase inhibitor. So this enzyme will think that this is beta-lactam. They are looking similar, but actually it is not beta-lactam. It is having a ring inside that beta-lactam ring just to attract the enzyme. But it is not beta-lactam. We have not sent the main hero. Main hero will do later on entry. It will do the entry later on. So this enzyme will degrade the ring of beta-lactamase inhibitor, thinking that it is beta-lactam antibiotic, but it is not beta-lactam. So as soon as the enzyme will come and bind with this will degrade the ring, but this will also inactivate the enzyme. दोनों एक दूसरे को मार देंगे. Both of them kill each other. So there is a villain. The villain is the enzyme. So we are sending the side hero. So side hero is killing the villain. Villain is killing the side hero. Now the hero is same. The main hero is the safe. So we will send the main beta-lactam antibiotic. Now enzyme is already degraded. So with the beta-lactam, we can give beta-lactamase inhibitor. We can give the combination. The combination is the best. So these are not penicillins. These are not antibiotics. They increase the efficacy of penicillin. They increase the efficacy of beta-lactam antibiotics. These are not antibiotics. Hana, they do not kill the bacteria. These do not inhibit cell wall synthesis. No, no, no. These are the humshakal of penicillin. They are going inside just to kill the enzyme so that the main beta-lactam will be safe. How many of you got it? Give me a thumbs up. You got this concept? So these are 3 in number: clavulanic acid, sulbactam, and tazobactam. Got it? So we give the combination. So same story is written in front of you. Beta-lactamase inhibitor themselves are not antibacterial, antibiotic. No, they augment the activity of penicillin by killing the enzyme. Got it? Got it? So that is the complete chapter. We have done penicillins. We have seen penicillins completely. Give me a thumbs up. Read the question, tell me the answer. Can you read the question and tell me the answer? Few MCQs we will do. Can you please read the question and tell me the answer? The following is not a penicillinase resistant penicillin. The following is not a penicillinase resistant penicillin. Yes? The options are methicillin, ampicillin, oxacillin, and neficillin. What's the correct answer? So penicillinase resistant penicillin, the mnemonic. What is the mnemonic? Which of the following is not a penicillinase resistant penicillin? So this one is penicillinase. All of them are coming in this option. Now you can see neficillin is also coming. Oxacillin is also coming here. Methicillin is also coming. But ampicillin is from the extended spectrum. It is not coming in. So you get many questions, although based on the mechanism of action or the classification. So the thing is, you have to learn the classification and main points about the main drugs in that. So acid labile penicillin kaun sa hai? Acid labile penicillin. Who is acid labile? So acid labile penicillin overall in सब में से acid labile penicillin का एक mnemonic है. The mnemonic is vodka, VODKA. V stand for penicillin V. O stand for oxacillin. D stand for dicloxacillin. K को C बना लो. Cloxacillin, and A is both A. Amoxicillin and ampicillin. You can mark. These all are acid resistant. Acid labile. Acid labile. Remaining all are acid resistant. So this is how, with the help of the mnemonics, you can learn the pharma. You got an overview that what we are studying and how we have to complete the pharma. You got an overview. Is this session useful for you? Is this session useful for you? Say yes, say no, say something. Huh? Is it good? So today the plan was to complete the 5 systems, but out of the 5 systems I have completed only 3. Still we have to go ahead. Now we have to complete CVS, which is pending for today, and respiratory system that is pending for today. But you know, I'm not feeling very well to continue it right now. But I will provide you the notes for this if you want to read it right now. But I will definitely take a session. You know, the part 2 is already scheduled on the same YouTube channel. I will continue the remaining complete sessions in that. So don't worry, I'm not skipping anything. Don't think that I'm skipping. So today I have completed the pharmacokinetics, pharmacodynamics, and a half of antimicrobial, not the complete one. Just a second. Yeah. Remaining all are still there. So these all are pending. You can see these all are. Anna, so I will schedule all these a long complete day marathon. Anna, so in a complete day marathon, I will give you all these the complete systemic pharmacology. Don't dare to miss that session. That is going to super simplify your systemic pharmacology in one shot. Don't dare to miss that session, please. The session is scheduled on 13th of January. And it will be specifically FMGE oriented, in which I will cover the PYQs of every system, each and every. I will start with renal system, respiratory system, CVS, ANS, CNS, GIT, endocrine, autocrine, blood, and anti-cancer. So I will not go in much detail, but a little bit about all the systems and the important areas from which frequently the questions are asked in FMG exam. So we are going to discuss it complete in a rapid super manner. But yeah, the marathon will be at least of 5-6 hours, because I require at least these hours to complete all the systems, the important points among them. So the session is on 13th of January. Please mark the date. Please mark the time. The session will be from 6 p.m. onwards till 12 in the night. So it will be a 6-hour marathon, okay, in which I'm going to take it. So currently I'm really sorry I couldn't finish it completely, but I'm definitely going to take it in the next session. Okay, so I would like to end the session now and see you in the next session. Okay, so please make a reminder and come back in the systemic pharmacology, and you will see I have a very unique way in which I take the systemic pharmacology. I teach the pharmacology in comparative tables. whatever drugs I will teach you now, like diuretics, I will teach you. So I will compare the furosemide, the thiazides, the carbonic anhydrase inhibitor in a comparative manner. So all the drugs, I'm having a fixed set of headings. I call them master tables. So in that, I compare the drugs. So I will tell you the classification of that category if it is having. After that, we will see the mechanism of action. After that, we will see the adverse effect. For that, I will give you the mnemonics. I will tell you the uses. I will give you the mnemonics for that, and contraindications or any other important point if applicable. So I will provide you tables. So at the end, you may be having 20 tables with you, in which most of the pharmacology get compacted in a super simplified manner. So I am going to teach you the remaining pharmacology in the form of tabulated manner, so that it will be easy for you to grasp during the last time, and you can revise it very quickly. You can revise it in hardly 2-3 hours, the complete systemic. But the general was a big chunk that we have completed today. Thank you so much. I hope you found this session useful, and we will meet soon. Okay, bye-bye. I'm just ending it. Thank you so much. Thank you so much. Bye-bye.